buenos días. Good morning, everybody. First of all, apologies for this light delay. We have been opening the other parallel meeting with the Ibero-American Network of Regulatory Medicines Authorities. So this is a busy day, a busy agenda, but we are delighted and really excited to finally open this meeting that we have been prepared with so much enthusiasm. I hope you had a lovely and relaxing evening in Pamplona yesterday and you are full of energy for this day. It's a great pleasure to host this meeting together with EMA and HMA to remark the importance of regulation in the fight against AMR. It will contribute to promoting the right measures to encourage the prudent use of antibiotics. AMR is a complex, cross-sectorial challenge that demands a multifaceted approach. Together, we must join efforts to fight AMR, preserving the efficacy of antimicrobials for future generations and ensuring the health and well-being of our citizens. This morning, we are going to review the European Medicines Authorities Network Strategy on AMR for EU medicines. Our agenda is meticulously drafted to provide a comprehensive understanding of the EMAN's strategy and its implications, assessing past accomplishment and envisioning a more reinforced future against the threat of AMR. Beyond these presentations, there will be time to focus on surveillance of consumption and resistance in both humans and animals at European level. There will also be room to expose the EMA concept paper on diagnostic tests for responsible antibiotic use in animals. But most of our efforts will be consigned to oblivion without implementing communication strategies. This is the reason why we believe it's important to dedicate this afternoon to a roundtable on this subject, and we are honored to have with us some of the key persons on communications in Europe. I encourage you to make the most of this day, ask questions, share your ideas and experiences, and actively participate in all scheduled activities. Diversity and perspectives and collaboration are the keys to addressing the challenges we face in AMR. Before I give the floor to my dear colleague Björn Eriksson, General Director from the Swedish Medical Products Agency, I would like to remark how important it is to align strategies at a global level and never forget regulation is a key tool in our toolbox. So welcome to Madrid. Björn, please, the floor is yours. To Pamplona.
Thank you, Maria, and great thanks to the Spanish Presidency for arranging this very important meeting. And health is a global challenge, and what's happened in one part affects all other parts. In the world of infectious diseases, you can say that no man is an island, nor diseases, pathogens like bacteria or countries are islands. Therefore, it is a strong call for cooperation and structured coordination. And we all have to fight the antimicrobial resistance. As regulatory authorities, we need to identify and apply powerful tools and to recognize the interdependency between human and animal health, environment, human and veterinary medicine, the One Health perspective. Regulatory authorities can achieve a lot. This was obvious during the quadripartite meeting in Geneva in May this year. Quadripartite is the joint platform between WHO, FAO, the United Nations Environmental Programme, and the World Organization of Animal Health. Next autumn, the United Nations General Assembly will focus on antimicrobial resistance. and to deliver for next autumn a powerful regulatory toolbox that could be used worldwide. The Regulatory Authorities Global Network was formed, and this is abbreviated RAGNA. The objectives of this network is to strengthen the international collaboration between regulatory agencies combating against AMR, identify concrete actions the regulatory agencies can contribute with against AMR, and exchange experiences and good practices between regulatory agencies, human and veterinary medicines against AMR. So during the years of this threat of increasing resistance, powerful and impactful tools and actions has been made. They have been identified and they have been used. And in the RAGNA context, after just 2 meetings, we have about 100 regulatory interventions and actions that we have identified that could be used worldwide. The actions we have identified is about, of course, to decrease the use of antimicrobials, both in animals and in humans. This could mean a more rigorous control of the use in animals. It could mean to prohibit over-the-counter sales of certain entities. It could be to limit prescription of broad-spectrum antibiotics. It could be through recommendations and follow-up or a legal restriction. The tools are addressing the volume of packages we are selling, the number of tablets expedited in pharmacies, the use of point-of-care diagnostics to exactly identify the bacteria during the physician-patient consultation, or the use of antibiograms in general practice, allowing the prescriber online to use the correct narrow-spectrum antibiotics needed. The list is long, and the number increases. There is vast experiences, and it is shared in the network. The importance of involving all parts, governments included, has been stressed during the work so far. I'm looking forward to these 2 days, and a great thank you to Maria, to the Spanish Presidency for, in very turbulent times in the world right now, arrange this important meeting and addressing antimicrobial resistance. So, very welcome, everybody.
Correct. We can listen to Imer Cook, from the Executive Director from the European Medicines Agency. Can we have the video? Yes, Christiana? Video in, please.
Ladies and gentlemen, good morning. It really is an honor to address you here today at this critical conference on One Health and antimicrobial resistance in beautiful Pamplona. As you all know, antimicrobial resistance, or AMR, is a serious and growing threat to human and animal health in Europe and around the world. This means that we need to take urgent action together. AMR endangers the efficacy of life-saving antibiotics, antivirals and antifungals that underpin modern medicine. It makes even routine medical procedures risky. Inaction will have dire consequences, with estimates suggesting that by 2050, AMR could claim up to 10 million lives annually. AMR could surpass cancer as a leading cause of death globally. The fight against AMR is therefore a high priority for EMA. So what is the EMA doing to fight AMR? Well, we support the development and approval of new antimicrobials and alternative treatment approaches. We promote the responsible use of existing antibiotics. We collect antimicrobial consumption data for antimicrobials used in animals to guide policy and research. And we contribute actively to other EU activities on fostering development of and access to antibiotics. So what does that mean in practice? Well, new antibacterials are urgently required for several human pathogens. There are simply not enough new classes of antibiotics under development. So we need to bridge the gaps and support the development of new and innovative medicines that can fight multi-drug resistance bacteria. This means we need early dialogue and constant interactions with developers focused on innovation, particularly small and medium-sized enterprises and academia. This is really key. But we cannot do this alone. AMR does not respect borders. The European Medicines Agency is in regular contact with regulators from other jurisdictions such as the US FDA, Health Canada, Japanese Pharmaceuticals Agency. Together, we ensure harmonized requirements for approval, recognizing the fact that AMR is indeed a global problem that needs global coordinated actions. We have also expanded our assessment procedures involving antimicrobials to non-EU regulators through the Open Initiative. In addition, we use real-world evidence to monitor prescribing of antibiotics in humans using our Darwin Initiative. By better understanding how doctors in different countries prescribe, we can target measures to optimize the use of these products, maximizing their benefits and minimizing use that might increase resistance. Our responsibilities for both human and veterinary medicines place us firmly at the center of One Health approaches, clearly recognizing the links between the human and animal ecosystems. Antimicrobials must be used prudently and responsibly, both in animals and in people. EMA's veterinary team actively implements the new veterinary medicines regulation, which includes many provisions that are instrumental in the fight against antimicrobial resistance in the EU. For example, the use of antimicrobials in animals to prevent disease is only allowed in exceptional circumstances. Use of some antimicrobials in animals is even banned to ensure that these antimicrobials remain effective for treating people with certain conditions. We have also updated the categorization of antibiotics for veterinary use to guide veterinarians in choosing the most appropriate antibiotic for their needs. The agency collects data on antibiotic consumption in food-producing animals across Europe to help us identify possible risks that might lead to the development and spread of antimicrobial resistance. These data can then be used to inform our policies, and our joint work with European countries has led to a decrease in the sales of veterinary antibiotics. We have seen an impressive 50% reduction in consumption over a 10-year period since the exercise started in 2011. Results such as this show clearly that the more we focus, the more we work together, the more we can achieve. And this is the essence of the One Health approach. Platforms such as this conference in Pamplona are crucial. I urge you to use this forum to share your insights, your experiences, and your solutions. Let us foster a global dialogue that transcends borders and disciplines. Together, we can develop a comprehensive strategy to address AMR effectively and preserve our ability to treat infections and save lives. Your efforts will contribute significantly to the global fight against AMR. I really look forward to hearing the outcome of these discussions and to future collaborations that will help us shape a healthier and more resilient world for generations to come. I wish you all a productive and insightful conference. I wish I could be with you. Thank you very much.
So thank you, Imer, thank you, Bjorn, for your inspiring words. I think that we can see how regulators are key to fight against MAR, and this is the aim of the next table. I've mentioned in my opening words the strategy of the European Medicines Network to 2025, and one of the main strategic pillars is AMR. We count on this table with the two topic leaders from HMA and EMA, respectively. Professor Dr. Thomas Heberer is the head of the Department of Veterinary Medicinal Products at the Federal Office of Consumer Protection and Food Safety in Germany. So Professor Heberer from HMA, and Barbara Freisgen, AMR Senior Specialist in the Veterinary Division at the European Medicines Agency. We are going to dedicate this table to review the strategy, the main actions, and then to discuss them. Thank you. You have the floor, Thomas.
Yeah, thank you so much. And thank you so much, Maria, and for the Spanish Presidency for the invitation. It's a real honor to be here, and it's a good opportunity to discussing our strategy, as we are just right now in the middle of the strategy for the first planned term. So it has been changed, if you will see right now. I'm happy that I can share this presentation together with Barbara Freisgen, because it's a joint strategy. It's an EMA-HMA strategy, and it's the second strategy. The first strategy was in 2016, and now we start again in 2021. So we are talking about the European Medicines Agency's network strategy. And hope we get the first slide, maybe. Oh. It's on this computer, but it's not right here yet. Now we got it. Thank you so much. That's the idea, to just present to you what has been achieved during the last 2.5 years. And of course, we are keen to see and to hear from your side what you think about the strategy. And probably we missed something, and you said, well, you have to add something to the strategy for the forthcoming years, because we are on a longer term, and I'm sure that this will be also part of the next strategy, because as had been mentioned before by Maria, by Björn, and also by Emer, this is an issue, an emerging issue. It's not emerging, it's already there, and it will be probably getting worse in the future during the next decades. So that's the strategy by itself. So it's a joint strategy, as I mentioned, between the EMA and the HMA. So EMA is clear, it's the European Medicines Agency, and the heads of medicines agencies is, from our side, it's a compilation of all the NCAs. So it's a network of the heads of national competent authorities. It's 40 national competent authorities which are responsible for the authorization and regulation of medicinal products for human and veterinary use in the European Economic Area. So this also includes Norway, Liechtenstein, and Iceland, and of course the European Union member states. So this is something we try to address all together also with EMA, because I think the close cooperation between EMA and HMA is essential for achieving something on the regulatory area. And the HMA itself is an informal body, but of course we all feel committed to this body and to those things that we are going to decide together, where we want to get forward in the near future. As you see, we had a first strategy already in 2016 to 2020, and this strategy originally was designed to be valid between 2021 and 2025. In the meantime, it has been extended until 2028 for two reasons. First of all, COVID. COVID had a real impact on the strategy and also on the measures that had to be taken. And secondly, it's, on the vet side, you probably know that we have a new legislation which has to be, which came into place in 2019, which is right now to be applied since January 28 of 2022. On the human side, we are still in progress of a new legislation, which is underway and probably will not be finished until 2025. And of course, we were all sure that we have to recognize everything that is going to be conducted within the strategy also in terms of this discussion progress. And I think Björn is deeply into the human progress of the development of the human pharma legislation. And I'm head of a veterinary agency, so we are right now in the implementation phase for the veterinary legislation since January 28 of 2022. And so what was the idea of the strategy? First of all, we had to identify shared challenges, goals, and priorities to give strategic direction to the work of the European Medicines Regulatory Network. And this is done by, well, the question was how the network will continue to enable the supply of safe and effective medicines was one issue in the face of the developments of science, medicine, digital technologies, globalization, and emerging health threats, such as the COVID pandemic, which just came over us during our preparation of the strategy. So we finally outlined 6 priority focus areas within the European Commission's roadmap that has also been addressed within the pharmaceutical strategy for Europe. And these are the 6 areas, and each area has a person assigned to as a theme lead. So we have 6 theme leads, and the reason why I'm here, I'm just head of theme lead of theme number 4, which is AMR and other emerging health threats. But we have other issues like availability and accessibility of medicines, data analytics, digital tools and digital transformation, innovation, supply chain challenges, sustainability of the network, and operational excellence. And you could imagine that all these themes are interlinked to each other. So, and finally, AMR is an issue that also concerns many of the other areas. So it's very important that we are going to exchange our experiences, and we will take back the messages from this meeting also to the next meeting of the strategy group, which will, Björn, I don't know when it is. I think it's in November, I guess, probably, when we are talking again. And of course, we try to interlink all the issues that we are going to discuss right here with the other themes. So, here we go. So if we are just looking deeper into the theme number 4 on antimicrobial resistance and emerging health threats, other emerging health threats. So I think we still had a discussion in the very beginning if probably AMR is seen as an emerging health threat. And I always said, well, it's already there. So we're talking not about emerging health threats, but an existing health threat. And so the emerging health threats are things like COVID, for instance. So we had different strategic goals and still have different strategic goals within our strategy. First goal is to provide high quality information on antimicrobial consumption and surveillance data on antimicrobial resistance in animals and humans in support of the policy development. As I've mentioned, on the vet side, we have already a new legislation which has to be implemented, and on the human side, it's still in development. So this strategic goal primarily focus right now on the veterinary side. So the objectives that I mentioned right here are primarily set to the veterinary side. So adapt use and sales data reporting to new legislative requirements for veterinary medicine, spread knowledge and ensure better access to data in line with the veterinary medicines regulation. And this is in regulation 2019 number 6. And of course, we have a special session on this. It's the next session right after this session, and you will talk about this more deeply within this session. And I'm also keen to hear your thoughts on this and what we achieved yet. But we will talk about this also a little bit later right here. So the second strategic goal is contribute to responsible use of antibacterial agents and effective regulatory antimicrobial stewardship, a very important issue, we thought. So it's the question of just modernizing summary of product characteristics SPCs, as we call it in veterinary medicine, or SMPCs, as it's called in human medicine. It's just the same, and it just concerns old antibiotics for human and veterinary use, and we are, of course, know all that these SPCs have to be improved in future, and of course they have to be improved consecutively, just regarding the situation of the resistance. Number 3 is ensure regulatory tools are available that guarantee therapeutic options, especially for the veterinary medicines, but while minimizing the impact of antimicrobial resistance on public health and the environment. So right here, the objective is to promote guidance on antimicrobial use by adaptation of existing and creation of new guidelines and finalize the agency approach to antimicrobial resistance in the environment. So it covers different areas. First of all, of course, the therapeutic area, but secondly, also the environment, and we will be talking about this later. It's an issue which is still in progress, but we are, I think, Barbara, we're on a good way to get something done within the next few years. In general, this is a very important goal, especially for the veterinary side, because we know that we will not get any new antibiotics for veterinary treatment. So we have to keep the old antibiotics and to make them, have to keep them effective within treatment. So next 6, we almost got it. So it's 3 other goals. First goal is define pull incentive for new and old antibacterial agents. And you could, of course, imagine that pull incentives for new antimicrobial or antibacterial agents just concerns primarily the human sector, whereas the old antibacterial agents primarily concerns the veterinary sector. So the objectives here are to define value of new antibacterial agents, to inform new business models, and to cooperate on the establishment of new business models, including the exploration of incentives for continuous manufacturing of old antibiotics. So we know that we, of course, are very dependent on innovation by manufacturers, and of course, the manufacturers need some incentives to do innovation. I think it's our possibility to influence the manufacturers to just design new antibiotics or just to redesign old antibiotics. Number 5 is foster dialogue with developers of new antibacterial agents and alternatives to traditional antimicrobials. Objective right here is to foster development of new antimicrobials, including new antibacterials for human use, of course, because we know that they will never ever been authorized for veterinary use. Define regulatory pathways for FADE and other innovative products in human and veterinary medicine, and engage with relevant stakeholders to effectively discuss this issue. And this is something that concerns both areas, human and vet. So you see, of course, this approach for both sides, but we know and we are aware that some of the issues primarily are interesting for the human area in general, and sometimes also for the veterinary area. And we have number 6, it's improve regulatory preparedness for emerging health threats. This issue was introduced when the COVID pandemic appeared, and well, we thought, where could it be located within the 6 themes? And finally, it was decided that it probably fits within antimicrobial resistance. I was not so sure in the very beginning, I have to confess, because for me, antimicrobial resistance is a health threat, of course. It's an ongoing health threat, and it is something that is probably very special compared to other emerging and, well, finally fading health threats, hopefully, as far as COVID is concerned. So we have, of course, some objectives within. It was refine regulatory activities in inter-epidemics periods to increase preparedness and harmonize regulatory framework and approaches for investigation of medicinal products during emergencies. And of course, we made a lot of experience over the last years. I think it was finally working out very nicely. Also the cooperation again between EMA and the HMA. And I'm very happy to say that this was a very, very good cooperation between EMA and HMA. And Maria, she was also deeply into this issue. And of course, yeah, finally we striked it out. So it's not part of this strategy any longer. Why? Yes, because we have new instruments and new responsibilities. So in the very beginning, we had an HMA working group for crisis management called WGCM. This group does not exist any longer because it was not necessary any longer, because we have new instruments and new responsibilities. So as you probably know, the EMA has a new mandate, which was in the regulation of 2022, 123. So it was the role of EMA in crisis management was reinforced. And we thought, okay, right now we need something else. And what we have right now is an executive steering group on shortages and safety of medicinal products. And yeah, the three of us, we are all taking part in this steering group. And this is, of course, led by EMA. And on the HMA side, we have a working group of communication professionals, WGCP. And for harmonized communication in the event of any crisis in cooperation with EMA, this working group is very, very valuable. So again, we still try to align as much as possible with EMA, just to have the measures that have to be taken, of course, to observe any kind of shortages that may appear. And on the other hand, if something has been decided and has to be transferred on a national basis, we need somebody to do the communication, and we decided that this should be this working group on communication professionals. So finally, these groups took over the responsibilities of the strategic goal number 6, so this was striked out. And now we can concentrate again very intensively on AMR, and I think this is still a large area to work on. So what are the main activities? Again, so coming back to goal number 1, so it's about the consumption and surveillance data on antimicrobials, and as I said, it's adapt use and sales data reporting to new legislative requirements for veterinary medicine, spread knowledge and ensure better access to data in line with the veterinary medicines regulation of 2019. And you can see right here what has been done. So we had to implement use data collection by animal species. So this is a tiered approach on the European level. So what we need right now is not only sales data, which have already been accessed for a longer term, different by different member states, but of course we also have EMA collecting these data, and they are published year by year. But we know that finally what we need is not only sales data, but use data, more specifically for animal species. And so we have an HMA working group on the implementation of use data collection by animal species, and you will have the session right after this session where you get more detailed on this. Just in advance to tell you what we are doing right there is we give guidance to all veterinary NCAs on the transfer of data, to the insurance of data quality management, and of course on communication, and finally guidance also to EMA on the transfer of data to EMA, because finally all the data has to be collected by EMA. So we started this year, in January this year, with the first species to collect data on use, and of course we try to do it on a national basis, and we will transfer these data, I think, until March next year to EMA. And as I said, it's a tiered approach. First of all, we're starting with food-producing animals, and later on, finally, we'll include cats and dogs and other pet animals. And this is set until 2030, so we have to be, of course, elaborate databases. And of course, the challenge is that it's very different to collect data from animal species which are grown at farms, or from pet animals which are treated very differently. So especially the second, it's not 2 steps, it's even more steps, but when we are collecting data from pet animals, it will be very, very important to have a system that's working, and it's not that easy, as we learned right now, but we are in close exchange, and I think the HMA is a body which is, although it's informal, a very good option to exchange experience from each other, to learn from each other. And I'm very happy that we are, well, making progress, and you will hear more about this later on within the next session. I think, Barbara, it's your turn right now.
So I'm right, thank you. The microphone's on now. I will go into more detail on how we had to prepare the system in the EU for the collection of sales and use data. The veterinary medicines regulation only gave the broad outline. There were a lot more regulatory steps to be taken for member states to have clear guidance on how to set up the systems to collect use data in the different animal species. And the agency prepared 2 scientific opinions for the required follow-on legislation that then led to the Commission delegated regulation on the requirements for the collection of data on the volume of sales and of use in the different animal species for antimicrobial products used in animals, and then a secondary implementing regulation that defines the format in which the data should be reported to the agency. Now that's telling people what they should do, and then you need to develop the IT systems that make it possible to report these things. And Thomas already mentioned it, it had to be done in collaboration between the agency and the member states. The member states hold the data both on the veterinary products and, of course, the data collected on sales and use of antimicrobials used in animals. And we at the agency just need to compile it in a system that makes sense and that later makes analysis very easy. So we designed, together with member states delegates, the system, we call it ASU, that's going to replace the current SVAC reporting system for only sales. But the ASU system will capture both sales and use data for antimicrobials used in animals. And I can report that so far we've been quite successful in building the system. The platform is live and integrated as defined in the Commission implementing regulation with the Union product database. If you look into the regulations, you will see that we will continue to capture use data and sales data at the package level. That is defined in those regulations, and it's also defined in the regulation that the reporting has been done using the Union product database. There is a good reason behind that, and the reason is that you want to minimize data entry. All the data on the veterinary medicinal products authorized in Europe are currently captured in the Union product database. It's a new system under the veterinary medicines regulation, but it's the first time you've ever had an overview over all EU authorized products. And it simply makes sense to build on the great work that was done on that system and utilize it for the reporting of the antimicrobial sales and the use data. It still requires more instructions, and so the protocols for reporting of sales and use data have been published currently separately, but they will be integrated going forward. And templates to do the reporting have been published as well, so member states could really prepare how to do the work. It's important to recognize, Thomas mentioned already, collection of use data in companion animals, especially in companion animals. Also, human medicines may be used on occasion, and therefore the system cannot only capture veterinary medicines. It needs to be larger than that and will also integrate the already available data on human medicines, but luckily companion animals are coming a bit further down the line. So it is something that will be continue to be developed over the next few years until we really have the whole breadth of the data collection covered. It sounds so easy, collect cells and use data in animals. But then you need to know what to do with the data. What do you do when you have the data? How will it be reported? And that was part of the work that was done in the current year. So a guideline. No, sorry, I have to start out differently. First, because we do collect data by animal species, and again, we try to use data that is already publicly available. So we build on the data available in Eurostat, which is the agricultural statistics reporting of the Eurostat. It's the statistical office of the European Union, and agricultural statistics are only a little bit of what they do, but the important bit for us. Now, you don't just report bovine. They have about 20 different lines for bovine that can be reported. So we needed a manual that guides member states in how to compile the different categories available in Eurostat into the reporting that is necessary under the new veterinary medicines regulation, and that was done with the manual for the reporting of the data to the agencies. It purely focuses on how to compile the data for the different animal species, and then we go to what I mentioned before. How do you then analyze the use and sales data that you have? And the guideline on the reporting of antimicrobial sales and use data was adopted just last week and should be published on the agency website now. It's not a static system, and it will require further development. It will require also member state input into how the data should be analyzed. And for that purpose, we have set up what's now called the ESWA VET Working Group, European Sales and Use of Antimicrobials in Veterinary Medicine Working Group. And this group will really be the vehicle by which we further develop the scientific background of the reporting, but also questions that member states may have with respect to data quality management plans. So it's a very specific group all around ensuring data quality of use and sales data reported to the member states and then to the agency, and then subsequently the analysis of the data. And even though we just published a guideline, we will also look at it and make sure that this is really the best way of analyzing the data going forward. And we're already planning to have discussions in the coming year. Ima, in her address, already mentioned that we don't focus only on the veterinary side, that's my specialty, but we also do a lot of work on the human side. And in particular, the Darwin project in the EU that looks at real-world data on how medicine, among others, on how medicines are utilized, will provide important information in understanding how antimicrobials are used in human medicine and what could be done to direct the prescription of antibiotics in the desired direction, which is really use as much as necessary, as little as possible, and simply ensure responsible use of antimicrobials all around. I don't think that our desire is to reduce use per se. The outcome is to keep antimicrobials working and to reduce the development of resistance, and reducing sales and use is just one measure for that. Yes, I think we can now move to the next strategic goal. Thomas already ran through them in the beginning, and this is really to contribute to responsible use of antibacterial agents and effective regulatory stewardship. We had the two objectives of modernizing the SMPCs for old antibiotics for human and veterinary use, and also to define a roadmap of point-of-care diagnostics to support the development of improved diagnostic tests. Now, that is, of course, very important in human medicine, but just as important in veterinary medicine, where we also don't have the required tests available when they are needed. And I will kick off again with what's being done on the veterinary side. And we are developing a number of guidelines at the agency. And if you understand how the agency works, that's always done together with the member states, either through one of our scientific working groups that report to the committee, or in the end, the committee is a member state expert committee that will adopt those guidelines. So the agency may lead, the member states do the hard work. So the guidelines we're currently looking at and is first and foremost a guideline on the assessment of the risk to public health from antimicrobial resistance due to the use of antimicrobial agents in veterinary medicines. Antimicrobial veterinary medicines in food-producing animals. So really to make sure if you use an antimicrobial in a cow or in a pig, will that have consequences for public health? We do know that it does, but this is a guideline on how we want to assess the risk. The next paper we're working on is a reflection paper on the use of some critical antimicrobial agents for human use in food-producing animals, and again looking at the development of resistance and impact on human and animal health. And those critically important antimicrobials are the macrolides, lincosamides, and streptogramins. So watch out for that paper. It'll be interesting reading. And last but not least, one of the provisions for the veterinary medicines regulation, which is very strict on ensuring responsible use of antimicrobials, but also understands the need to incentivize innovation, is a guideline on the data requirements for post-authorization studies for antimicrobial veterinary medicinal products. Sorry, I was in my thought already on a different topic. I'll get back to that later. But this one is really something that is still aimed at ensuring responsible use of the antimicrobials. And with the next slide, we go back to Thomas.
Yeah, thank you so much. Well, just staying with this goal 4.2, we also have, as I mentioned before, and you also mentioned it, we need to preserve existing therapeutic options, of course, and by continuously raising awareness through the education. That's a very important issue. And if you did not hear about it yet, so we have a so-called EU NTC steering group. This is a very important steering group, actually, just to compile the needs for education. So we have a continuous elaboration within the steering group, also to organize the training activities, to identify and formulate specific requirements in this area, and Well, I got the honor also to be part of this NTC steering group representing the veterinary side, but of course we have both there, especially also the human side has some influence on this NTC steering group. And what is NTC? NTC was initiated by Guido Rasi, where several years ago, I still recall when he came to us and said, well, EMA wants to set up something new. And this was this National Training Center, NTC, approach. And he said, well, we want to set some incentives that you're going to teach and train each other's, the different agencies. So to learn from each other, to harmonize approaches, this was a very initial idea. And I know that Christa Werthümner, she was very, very active in this group, and we set up a network of different, with all the agencies, we have so-called, what are they called, training champions. So each agency has its training champion, and they're going to meet. They're going to do the operative work, and the NTC steering group is more for the strategic approach. So we also had interviews very recently. So how are we going to proceed in the future? Because NTC program will be having its 10th anniversary next year. So we have come very far, but we also need probably your input from your side. And that's, so it's an opportunity today to give us some input, what you think, what we should address within the NTC training program. And I think AMR is a very important issue that has already been addressed and should be addressed in the future within the NTC training program. So what did we do again on the human side? There's a prioritization list on Article 31 referrals that has been prepared, which I've learned today, which is ready right now. And we have a concept paper for development of a reflection paper on the availability and characteristics of diagnostic tests to improve the responsible use of antibiotics in animals, and this will also be a session today. So session number 3 is addressing this special issue, and I'm very keen to hear about the progress in this area. So this is something coming up. So I think I hand over to you again right now.
Yes, thank you. Yes, and we're going back to a reporting of the activities of the Committee for Veterinary Medicines. These are guidelines that were developed for stakeholders, and the stakeholders might be industry, the stakeholders might also be the national competent authorities. And again, if you see something that is missing from what has been done, as Thomas just said, we'd be keenly interested in hearing from you what's missing from this strategy, but you need to bear in mind we're regulatory authorities. So what we're trying to do is ensure that medicines come to the market as smoothly and as fastly and as best advised as possible. But that's what we do. We put medicines on the market, and there may be other gaps in the picture of having a really good plan to address AMR that we simply don't have the means to take forward. But something that we can take forward is that the CVMP, before even the strategy was put together, had a pilot project that looked at whether the indications for old veterinary antimicrobials could be supplemented with additional information, and in particular pharmacokinetics and pharmacodynamic modeling data to ensure that we have appropriate dosage recommendations based on current understanding of the resistance in the different pathogens. And we published a reflection paper on what CVMP thinks they can do in the context of dose review and dose adjustment for existing veterinary antibiotics, it's something that's handled by national competent agencies and coordinated by a different group. We call them CMDV. It's the national veterinary agencies at the EMA. We will publish, we're looking to establish a priority list there as well, and work has begun in interviewing all the stakeholders. So it'll come to the veterinary organizations, to industry, and anybody who might also have data available on resistance. The idea is really to establish a priority list of substances we should be looking at to ensure that the appropriate dosage advice is given in the SPCs, and recommend that to CMDV for implementation. This goal is about responsible use, and Ema in her address mentioned that the veterinary medicines regulation has a number of restrictions, or not restrictions, but specific guidance on how veterinary antimicrobials should be used. And some of them needed scientific advices from the agency to the Commission, so that they could develop again the relevant implementing legislation. And as sort of a last, well, as the most restrictive measure in the whole pyramid of measures that this regulation contains, the Commission was charged with developing a list of antimicrobials that should be reserved for human use only. And one has to see it as that. It is really the utmost and most restrictive handle we have. In order to draw up that list, first, an advice had to be developed on the criteria that should be applied in order to prioritize the different antimicrobial agents. And I'm saying antimicrobials because it was more than just antibacterials. We looked at antifungals and antivirals as well. And so you have the definition of the criteria that led to the Commission Delegated Regulation 21/1760, and then applying these criteria, we had a set of experts nominated from the heads of the medicines agencies, and including microbiologists, human infectious disease specialists, and of course veterinary specialists, to develop the recommendations for substances that should be included on a list of antimicrobials reserved for human use, and this list was published in Implementing Regulation 2022/1255. A separate advice we developed, again looking at responsible use of antimicrobials in veterinary medicine, is the advice on a list of antimicrobials not to be used in accordance with Articles 112, 113, and 114. We call it the cascade advice, in short. What that means is that because you deal with so many species and so many diseases, in veterinary medicine you do not always have the appropriate medicine authorized for something you need to treat in animals. And there is a derogation from actually using medicines only in line with the authorized SPCs for certain veterinary medicines under certain conditions, and that's captured in those articles. Now, the regulation says, are there any antimicrobials that, in order to ensure responsible use, should be restricted, should not be allowed to be used under the cascade, or should only be allowed to be used under certain conditions. And this is set out in the advice that the agency published, I think, in February this year. So for practicing veterinarians, it's actually really interesting. The Commission is working on transposing that scientific advice into regulation. And as all of you know who've worked at the crossroad of science and legislation, that's not always an easy task. So I think on this one, we're in the area of not easy. I think I'd like to move to the next slide. Right. This one goes back to Thomas.
Yeah, thank you so much. Well, this is we're coming now to an area which is very, very difficult to say. So there's also a concept paper that has been prepared for a reflection paper on the assessment of AMR development due to the presence of residues of veterinary medicines in the environment by Environmental Risk Assessment Working Party. This has just been started. I know what I was talking to Barbara before, that we had this discussion already since 2011, that we're not really sure how to assess and how to conduct a risk assessment, environmental risk assessment of antibiotic resistance in the environment due to exposure by antimicrobials, which is not easy to have target points, etc. So, of course, this is something that is difficult, but nevertheless, we have to do something. And because we know we are talking always about One Health, about humans, animals, but also environment. So it's part of One Health approach. And so we really have to address this issue. And we are trying now to address this issue very intensively, because we know that this is something that has to be done and desperately is sought to be done. Communication on available tools like AMEC categorization to stakeholders to ensure proper implementation and cooperation with working group of communication professionals is another issue. So we are coming back. I already made a notice, because I think communication is also key. A key because we are not living in our own world, but we are living in a very complicated world, as has been mentioned today. And this complicated world needs also to convince others and to gain public perception. And to gain public perception means that we have to communicate. It's not only doing good things, but to talk about good things to be done. And also to emphasize that we are already on track, because I'm receiving many emails from one member of the European Parliament, and they are probably a little bit, they said we have to do much more and we have to advance, Yes, we do. And we did something, and sometimes we feel that it's not recognized what has already been done. Of course, doesn't mean that we can stop right now, but we have to progress. But sometimes we also have to talk about what has already been done and has been achieved, and that the situation has been recognized as being crucial, and that we do something to improve the situation. And the question is, how can we measure the improvement of this situation? And especially in the environment, it's getting very difficult, that's for sure. So handing back to you, Rainer.
Indeed. And back to the guidelines.
Back to the guidelines.
I shouldn't put it down, because I do think the guidelines are very important to set out what the regulators think, what they expect. And it may just not be very interesting for you to hear, but we do also have a guideline on the assessment of the risk to public health from antimicrobial resistance. I think I mentioned that one already. And the reflection paper, I'm not sure, I think it could have looked at the slides again, but they are very important in defining the value of antimicrobials on the veterinary side. And moving on to the next slide, these are the guidelines that are really looking at supporting the development of alternatives to traditional antimicrobials, because, as Thomas already mentioned, we do not expect many new antimicrobial classes forthcoming for use in animals. So apart from using the existing antimicrobials in a smarter way, we also need to look at therapeutic alternatives, and those can be, of course, vaccines to prevent infections in the first place, but they can also be alternative approaches to combat the infectious diseases. And therefore, we have a guideline on the development of and data requirements for potency tests for veterinary cell-based therapy products. We have a draft revised guideline on quality, safety, and efficacy of phage products in veterinary medicines. And we have a lot of implementing guidance for the new legislative approach of having a vaccine platform technology for veterinary medicines, and an easier swapping of the antigen in the vaccines. And that, of course, really requires the appropriate guidance to the developers of such vaccines. And that's listed on this slide. And to put it all in a cohesive way of thinking, there is the agency's reflection paper on promoting the authorization of alternatives to antimicrobials in veterinary medicine. And moving to the next slide, we do also do work on human medicines at the agency. Actually, we mostly work on human medicines at the agency, but because this strategy coincides with the implementation period of the veterinary medicines regulation, we actually had a lot to report on veterinary medicine. So on the human side, there is a draft working document on incentive models, both financial and regulatory, and as part of the review of the pharma legislation. We are supporting the discussion on pull incentives and of value of new antibacterial agents. I will come to that on the next slide. And the pull incentives already made it in the proposal for the revised legislation. So I hope in the long run, effective pull incentives will stay in. But also we promote the use of available regulatory tools at the agency to expedite the development of new antimicrobials for human medicines, but also alternatives. And we have quite a number of tools, in particular the PRIME initiative that fast tracks specific development of specific medicines that meet unmet medical need. That has been opened up to antimicrobials. In the past, it was not. We have the adaptive pathways of authorizing medicines, the Innovation Task Force for Early Dialogue with Developers of Medicines. That's also been taking up on the veterinary side. Early dialogue with the agency in any case, because that is really key to fast-tracking a product through the regulatory approval process. And then there are additional useful platform on the human medicine side, and that's the Infectious Disease Working Party, IDWP, and the, I think, Emergency Task Force, which is also now looking at how to fast-track new antimicrobials to the market. And we did work on the definition of the value of antimicrobials. It's, of course, in the therapeutic value, but there are a lot more values to be considered. And that is in particular important in the discussion with the health technology assessment bodies in the member states and the reimbursement bodies, because this is where then the real value is weighed up against money and the choice of the appropriate agents. Moving on to the next slide. Again, mostly focusing on human medicine, the International Coalition of Medicines Regulatory Authorities has made a declaration on antimicrobials. It's probably going to be put into much more proactive context with the Ragnar initiative that was mentioned earlier by Björn. And Ima already mentioned that we do collaborate internationally. So we have cluster activities with FDA and the Japanese PDMA and Health Canada on the development of antimicrobials and antifungals. We have specific quarterly discussions with the FDA on phages and other alternatives to antimicrobials. And a workshop together with FDA is in preparation to take the use of phages in human medicines forward, so coming next year. And I think that was a quick run through what we've done in the past years, but we're not going to stop there. So back to Thomas.
Yeah, thank you so much. No, we're not going to stop. We just started, actually. So the ongoing strategy implementation progress going on. So we have a variety of activities that have been initiated. You have seen several of these, but of course they have also been initiated and can only be initiated if they are supported. And we had the presidency trio of France, Czech Republic, and Sweden, who really took a special emphasis on AMR, which has been mentioned already. And of course, right now, the French presidency also had a high-level meeting on AMR, made some recommendations for actions to include the Council recommendation on AMR. And of course, the Swedish presidency has already been mentioned. Björn is right here, and we will talk about this tomorrow. Established Ragnar based on the Council recommendations on AMR, which is a very important step, I guess, it has been undertaken. And right now, the Spanish presidency, and I'm so thankful for this, that the Spanish presidency also put it very high on its agenda and organized this high-level meeting to discuss this issue any further. Something else coming up is, of course, the high-level meeting on the global agenda with the UNGA discussions on AMR, which will continue in September next year. And we have something coming up also in our agency that I want to promote a little right here. So you're invited. We will have a broadcasted symposium on AMR during the World Antibiotic Awareness Week, which of course is just starting with the World Antibiotic Awareness Day on November 18th, which is on Saturday this year. So we will have this meeting on Monday and Tuesday. So you're invited to join us at best face-to-face. So to join the discussions directly, but of course you're also invited to join us online, and it's all for free. So the only thing that you have to do to switch on your computer if you're online, or just to come around to Berlin, which is of course always a nice trip to go, although in November the weather is not that nice, I have to confess. So it's better to get to Berlin in summer, of course. But nevertheless, I think it will also be an interesting meeting. And yeah, so this is the program that we and the strategies that we wanted to present to you. And I also made some notices right now for the discussion. So I think something that we have to think about, which is also often combined and which is also interlinked, but sometimes it's also in the public perception mixed, is something we are talking about AMR, about antimicrobial resistance. Of course, we are accessing, as you know, the sales data already. We are now assessing and collecting use data. Of course, use and sales are interconnected to the development of AMR. But of course, we should not only focus on amounts, because finally, AMR is something else than just amounts and collection of amounts, because we're talking about prudent use of antibiotics. And think it's not an option to use no antibiotics any longer. And as you have learned probably, and there's also residues, it's another issue which is also mixed up sometimes, and we're talking about residues. On the other hand, I said, well, okay, we're talking about AMR, not about residues. This is something that really concerns me because I'm still teaching at university and having discussions with students, and it's something that we always need to explain to the public. But prudent use is, of course, the key. It's not new. We're talking about this for many, many years. And no use of antibiotics is not an option for us, even in veterinary medicine. Of course, it's important for human medicine always to have a large amount and a variety of antibiotics for treatment, but it's also necessary to treat animals. Of course, first of all, due to animal welfare, but also due to protection of humans, because the spread of zoonotic bacteria is something that has to be prohibited, and so antibiotics are and still will be in the future an important tool to interfere this connection anyways. So what we are talking about and what we want to do, and as Barbara said very correctly, we can't do everything because we are just a regulatory agencies, so we can only do those things that we are in charge of. But we try to do our best to help to fight AMR on a global scale, or first of all on a European scale. And what we have to do, and I'm very thankful for the Ragnar approach, because what I've learned already with Ragnar was that, of course, we can do whatever we want in Europe, but of course we are just part of a one world approach. And this is something that we sometimes forget as Europeans. We think, well, we are just focusing on ourselves, we are doing something, but sometimes we have to recognize that in other parts of the world, there are also some very important ideas and approaches that we have to recognize. And so I'm very thankful for this approach, because I think this discussion is ongoing, and it's just one world, as Imar also said, one approach. And of course, we shouldn't also not do something that has been done in the past in Germany, that we separate human health and veterinary health. So this is one approach. And of course, the pressure on the veterinary side is much stronger than it is on the human side. Not only due to the new legislation, but also because often, the public is just looking at especially food-producing animals as the main reason for the spreading of AMR. I'm sure it's not, but anyways, I think we all have to work in our different areas, and we have to do something like a combined work, and this is what we are trying right now within the HMA network, just to combine our efforts on the regulatory side, just to deliver something to the public which enables us to fight AMR on a European scale, but also right now even more combined on the global scale. And I think we talked quite a lot, so we want to listen right now to you. Thank you so much for your attention, and thank you so much for your input.
Thank you. We have a few minutes left, and I think that Cristina, my colleague and coordinator from the bedside of the Spanish Action Plan Against Antimicrobial Resistance, I think we can open the floor for questions and discussion. Would you like to moderate it?
Yes, thank you. First, allow me to say hello to people connecting online. I remind you that this session is hybrid session, so we have connecting more than 200 people. So thanks for joining to all of them. So now it's time for questions. It's very important your participation during this session. Even more, we promise better breakfast for those who ask questions. So please go ahead and please introduce yourself before and then ask your question or introduce your comment. So please, who is first?
Thank you very much. My name is Emilio Esteve. I'm the technical director of the Spanish trade association, Pharma Industria, the original medicinal products. And first of all, I want to thank you very much to the speaker for their presentations. And I have two very general questions. Not, well, for the speakers or for the rest of the participants in this. Strategic goals 4.4 and 4.5 require, of course, a coordination with pharmaceutical industry for developing of new antibiotics and antimicrobials or for human and veterinary use, and to reconsider the old ones, and etc. In your opinion, as national competent authorities, do you think that the steps that are being taken would be enough to change, to address the current dynamic of progressive lack of interest of the part of the pharmaceutical industry? Because as I see in the objectives, there are many very well-known things, the prime guidelines and etc. But perhaps it would be interesting to open a dialogue with the interest part. That's my first question. Mm-hmm. There are enough measures for try to solve that due to the lack of interest of the pharmaceutical companies. Mm-hmm. And the second one is perhaps more political one. Considering the magnitude of the problem of the antimicrobial resistance, do you think that the Commission proposal, and as we know, has been published so far by the European Parliament, asking for a new model, would interfere the legal solution? We need a legal solution for the future, because we have a very big problem. But we have the Commission proposal in one hand, the Parliament approach with another hand, which is very different. And what do you think the national competent authorities with that? Because in fact, we need a solution, and it seems that there is an agreement in that solution. And provided that the solution is needed urgently, what will happen? What do you think about this discrepancy? Thank you.
So thank you for the question. Maybe this second question much better for tomorrow's session, because it will be more political session than today. It's more technical. But thank you so much for the question. Who want to answer the question? Thomas, please.
Yeah, I try to answer the first question, which is, of course, also a very tricky question, I'm sure. Yes, we recognize that there is a lack of interest by the manufacturers, and we try to, and when we especially establish these strategic goals just to address this problem. We know that it's a complicated problem due to certain reasons, which is also different on the human and on the vet side. There are also differences. So just speaking for the vet side, we have some basic problems. So the basic problem first is that there's a strong dependence, of course, on the production of active ingredients of antibiotics in China, which is primarily produced in China. On the human side, it's China and India. This is something that we are very concerned of for a long time. We know finally the price decides where these compounds are produced, and of course the prices are way lower for the production in China than they are in Europe. This counterfies somehow of also the proposals that have been set on the political scale, that they said we have to bring back the production of pharmaceuticals to Europe. I know that for some of these compounds it's very hard to get back the production, because it takes a long time for the manufacturers to install the production, for instance, for penicillins in Europe again, if it has not yet been implemented. So it can take up to 10 years until you are able to produce these pharmaceuticals again, old pharmaceuticals. We're only talking about old ones. So that's an issue that we are pretty much concerned of for a longer time. Nevertheless, of course, finally money decides where the production takes place. And of course, if you have new regulation, and this is also something that we recognized on the veterinary side, so if we have some prohibitions, for instance, for the use of antibiotics restricted for human use only, it's not a real incentive to the industry. Yes. If we have something like we want to lower the sales and the use data, it's also not a real incentive for the industry, because this is something you make less money if you're going to sell your products in the European Union. So we know that some of the actions which are necessary, and we are sure that they are necessary on the one hand, also quantifies the attractivity of the European market for the industry. So what we have to find is, of course, a way getting through, and this is also implemented somehow in the new legislation, that, for instance, that you have the opportunity to have the production or for the authorization, that the terms for the exclusivity of the use of the authorization by one company has been extended. This was one incentive that has already been set. So this is also demonstrates that we really recognize this problem. But on the other hand, it's of course hard sometimes, especially on the veterinary side, to attract the industry to produce antimicrobials any longer if we're going to restrict it. And this is also the reason why we do not expect new antimicrobials to be produced for veterinary side at all, because we know even if you have a new antimicrobial and that is going to be a new antibiotic that is going to be produced for veterinary side, it will be a second-line antibiotic very soon. If you have a second-line antibiotics, the sales are very low, so it's not attractive to the industry. And you have something similar on the human side. So if you have a new antibiotic on the human side, it will also be something that is reserved for special cases. So this is also non-attractive. So what we need is our new business models to be found, which makes it more attractive to the industry to do innovation. And this is what we are talking about. And we are talking about these approaches also with the industry. So at EHMA, we always have stakeholder meetings on the vet side and on the human side. And of course, we get some input from the industry, and we try to recognize as much as possible when we are designing our strategy papers, when we are designing our guidance papers. So I just want to assure you that we try to recognize as much as possible the ideas from the manufacturer side, although we are in a very difficult situation that on the one hand we want to restrict the use, and on the other hand, of course, we need some incentives that manufacturers are still willing to create new antibiotics or to keep even the old antibiotics. Sometimes it's not only new antibiotics, but also to keep therapeutic options, which we are losing sometimes, especially in the vet side. I hope this answered your question somehow. It's not a solution yet, but we need this discussion and interaction.
Okay, thank you. Thank you so much. Here we have another question.
Thank you so much. My name is Christine Ordahl. I work for the Norwegian Institute of Public Health. Thanks, it's a pleasure. Very informative session, very interesting. Just on the previous comment, which leads into one of my questions, I think it's important to remember that the only data that we have on API production is trade data. So when we say that most APIs coming from China and India, that's based on trade, on sales. And we know that 70% of antibiotics are used in veterinary instances. So I think we need to be careful about saying that we're completely reliant on China and India, because we don't know. There's no transparency of API data. We do know, we've done some assessments from Norwegian perspective, looking at API, and thankfully using Swedish data, that we actually do have strong penicillin production in Europe. Sandoz makes a lot of penicillins in Austria. We also have a small company in Slovakia that's making penicillins. So that leads into my question about transparency. Is there anything that in your plans that is looking at greater transparency of API production? New Zealand does it. They publish it openly on their website. You can look up phenoxymethyl penicillin and see that it's produced by Sandoz in Austria. Any plans to do that? And also, second question, an unrelated question, fungicides. Are you also looking at fungicides? Because we're looking at antifungals for treatment, but are we also looking at the fungicides that are used in agriculture? Thank you very much.
Thank you. Thank you for the question. Who want to answer? Barbara, please.
I would like to kick off with the second part of your question. Yes, we are working on fungicides. There is currently a question from the Commission being worked on by 6 EU agencies, ECDC, EFSA, EMA, EEA, and I think JRC is also participating in it. That will really look at specific fungicidal resistance. So that's only a first step, but we are working on it. And the report is, I think it's coming out in 2025. So still a bit of work to be done, but we are actually looking at it. And certainly on the veterinary side, it's covered by all our activities. Now, we do not have many fungicides authorized for veterinary use, but at the European level, there is an eye on the issue. On the penicillin production, I would need to go back to what we actually do, but I do believe we have a database on APIs and also veterinary medicinal products production, which is public. So anybody can go in and see where does what come from. But I would like to check that, and then I will address the response to you personally. Thank you.
Thank you. Maria?
To complement the answer, what is public is the authorized API producers, but we don't know really which one is producing. So there is, yeah, and you are right that we don't have the exact view of the situation of API manufacturing.
So thank you. Thank you.
Try to. Yeah, thank you so much. Yeah, thank you so much for the question. Actually, you are right and wrong at the same time. Sorry to say that, because we actually know, of course, the producers, the API producers, because it's part of the authorization process.
But many
you don't know where it's
have 2 or
produced.
3 producers.
Yeah, it's right. But most of the producers in our case on the veterinary side are only in China, so there's no real option. So you're right that we don't know exactly where it comes from, but we know that most of our producers are from China. And I know that the situation on the human side is different from the veterinary side. And this is something that's very important to mention. You're right for the human side. You're right that there are also producers on the human side in Europe, but we had 2 cases which are very prominent in my mind. It was about benzyl penicillin procaine case where we had a problem in the past, and our producers were only in China, only. So it was just one producer, and there was a problem with QM at that time, quality management. And so the idea was to skip this producer, which resulted in a shortage on the veterinary side, not on the human side, because the producer in Austria was producing for the human side only. So we were asking this producer to produce also for the veterinary side, because they were producing only a few months a year. And they said we were not going to extend this production for the veterinary side because it's not fitting into our management plan. So we had no benzyl penicillin procaine because it was only produced in China. What was the reason? Because it's cheaper in China. So we were also asking if they're going to produce for the vet side. They said, of course, it's more costly. Human side is ready to pay for this. Veterinary side is not ready to pay for this because the companies are not getting this cashback value as they get it from the human side. So finally, and this is what my experience, and I can only tell you my experience, is that almost all producers of antibiotics on the veterinary side are located in China. And we had another case, and it was a case of gentamicin, you probably recall this. So we had a problem, a quality problem with gentamicin, because gentamicin, and we saw it first in pharmacovigilance on the vet side, because we had horses dying from gentamicin. Was also one case, I guess, on the human side. And we realized that we had some residues inside this production line, and was again only produced in China, gentamicin. So we had some discussions so that they should probably change the production, because it was possible to produce gentamicin without these residues. And this company was not ready to change their production, so they could use another protein for the production. And they said, we are not ready to do it because we are the only producer. So you can't tell us what we should do. We are doing what we want to do because we are producing for the global market. And so they were ready to reduce the residues, but they were not ready to change the process. And this was, for me, it was very, very striking to experience how much dependent we are on the Chinese market. And I know, especially on the vet side, it's primarily the Chinese market. We have been to China several times in the meantime, and of course, they are very polite. And of course, we are talking to those guys. And we are now in China again next week. But I'm sure that this will not improve our situation. And maybe the situation is a little bit different on the human side. But on the vet side, we are strongly dependent only on the Chinese market. And especially with antibiotics, not with other products. And just to add something, we're not only thinking about fungicides, we're also thinking about antiparasitics, because we also have a problem on resistance with antiparasitics. This is something that also concerns the veterinary side, primarily or only, but also the pesticide sides, because most of the antiparasitics are also insecticides. But thank you so much for your question. It was very, very important to mention this.
Yeah, thank you. Thank you so much. I've seen more questions, but unfortunately we have not more time. So maybe during the breakfast, you can, Lucy and Ricardo, approach to the speaker and ask directly the question. So thank you so much. Now we have the break. Please be here at 11:30. So thank you.
Check, check, check. Check. No, ahora ya no. Check, check, check. Vale, perfecto.
you should be able to.
The stage, speak with you, and the time and this
When you
wait a moment,
when you shared before, I can click like you did a few minutes before.
wait a moment.
We are being controlling
Test, test, test. Hola, hola. Can you hear me? Hello, can you hear me in the call?
Thank you. So thank you for coming back. Very much appreciated. I hope that the participants online are connected, although we are a little out of time. Now we are going to introduce the next two sessions. The first one is targeted to analyze consumption, collecting data, and further analysis of this data. As we have seen in the previous session, this is part of the strategy against AMR. It's important to harmonize the collection, to have common standards, and this inform further policies in the field of AMR. The second session will be targeted to diagnostic tools, how this can help to make a better prescription, and for that we will have also time to discuss. So without any further delay, we'll go to the session 2. Our panelist will be Katharina Hoffmann. Katharina Hoffmann, she's a scientific officer at the Federal Office for Consumer Protection and Food Safety in Germany. And then Dominique Monet, head of section on AMR and health-associated infections within the disease program on AMR in the ECDC. Both speakers are connected online. I hope we can have a good connection. And then we will have time for questions. My colleagues on the table will help us with moderating the question sessions. And Katharina, I see you on the screen. Perfect. So you have the floor, Katharina. Please stick to your scheduled times. This is a message for you, both sessions, the two first in the session 2 and the 3 speakers in the session 3, because we need to finish on time. So, Katharina, please take the floor. Have the floor, Katharina. Please stick to your scheduled times. This is a message for you, both the sessions, the two first in the session 2 and the 3 speakers in the session 3, because we need to finish on time. So, Katharina, please take the floor.
Thank you very much for the introduction. I hope everyone can see me and hear me. I am not seeing my presentation right now. Yeah, now I see it. Perfect. Yeah, thank you for giving me the opportunity today to present the one method of combating antimicrobial resistance, which is the surveillance of veterinary use data in Europe. Sessions of veterinarians. Looking at this figure, you can see that the central professions that are exposed highly are farmers and veterinarians, who have on one side close contact to livestock, but also to society. And of course, the livestock also transmits via the food chain to society, and also gives emissions into the environment. As well as the veterinarians for farm animals, there are also veterinarians for pet animals, and the animal owners, who are also exposed in both ways to the animals, to the pets, and as also to society. So I think it is very clear that we can all agree on that the challenge of AMR can only be pursued by the One Health approach. And I will explain in more detail how this is tackled strategically. My boss, Professor Hebra, explained already to you the HMA and EMA network strategy, and that a multi-annual working plan to 2025 was set up that was also already extended to the year 2028. And this is for protecting public health at a time of rapid change in a rapidly evolving healthcare environment. And the strategic focus areas are listed here again. We already heard about them. I would also like to focus myself today on the AMR and other emerging health threats. The focus area 4 was again split into different groups working on packages. And members from national competent authorities are working on the listed topics. You can see that 8 work packages were formed. I would like to focus today on the first work package, veterinary use data, which is formed by national competent authority members from Germany, Spain, Austria, France, and Portugal. And my office, the BVL, has the lead on this work package. And the strategic goal is to provide high quality information on antimicrobial consumption and surveillance data in animals to support policy development. Before I tell you more about our work, I would like to introduce to you the legal requirements we are following and responding to. The new European veterinary legislation, as the regulation 2019-6, is applying since January 2022. And its main goal is to strengthen EU action to fight AMR by ensuring prudent and responsible use of antimicrobials in animals, and the second, to improve data on the dispensing and use of antimicrobials in animals. And of course, national measures flank this action in order to intensify the combat against AMR. For us, the most important article for our work is the Article 57, which calls for the collection of data on antimicrobial medicinal products used in animals, as well as sales data. So it states that member states shall collect relevant and comparable data on the volume of sales and on the use of antimicrobial medicinal products used in animals. And all member states are obliged to collate this data and send it to the agency, which in this case is the European Medicines Agency. And the agency then will analyze and publish this data. Concerning the topic of sales data collection, there has been an established surveillance system in place in Europe already since 2011. And I would like to briefly talk to you about the ESWAG project, which is a voluntary call for data of antibiotic sales in European member states. And on the left, you can see the report from 2021. And I think it's very nice to see that 31 European countries contributed to this report on a voluntary basis. And the data has been going, the data collection has been going on for more than 10 years now. And I would like to stress again that this is only on antimicrobial veterinary medicinal products sold. So sales data is the topic of this report. And one thing I would like to mention is that, of course, the issue that all European member states are very different in size and in structure. So the European Medicines Agency came up with a population correction unit to briefly, or we abbreviate it as PCU. You might have heard of it. Yeah, the member states also have to report the numbers of animals kept or slaughtered in the respective country, and by that, the data is normalized to the biomass of the respective country to make the data the most comparable, yeah, between the different member states. Germany has been contributing to the SFAC report since 2011 and publishes the sales data nationally as well. And here you can see the development of the sales data beginning in 2011 until 2021. And you can see very well that the amounts of sold antibiotic veterinary medicinal products have been reduced by 65% over the last 10 years. And this was achieved by several national legal requirements concerning the prudent use of antibiotics, but also in the year 2014, a benchmarking system in Germany was built up. And yeah, it contains treatment frequency indexes which are published, and you can see very well that there is the highest reduction in the year from 2014 to 2015 by minus 433 tons. And yeah, this gives us a hint that yeah, legal requirements can actually have an influence on this data. Now let me get back to the use data collection. First, I would like to show you the follow-up on the regulation, the Article 57, in a form of 2 acts. Those acts contain closer instructions how to collect and report the data. In the Delegated Act from 2021, there are very clear instructions that member states shall put up a data quality plan. And moreover, the list of VMPs to be reported are given in a mandatory scope, and they are identified by ATC vet codes. In the Implementing Act, following in 2022, the data formats are set, such as that amounts administered have to be reported on package level and by using identifiers from the Union product database. For those of you who are not familiar with the UPD, it is a central European product database for medicinal products and contains veterinary medicinal products. And by using those UPD identifiers, of course, yeah, the data is again made comparable amongst all member states. So yeah, that all the data has the same yeah, identifiers. And another interesting thing in the Implementing Act is that was already mentioned before by Barbara and Professor Hebra, is that a stepwise approach is possible in the use data collection, starting with farm animals, and the reporting has to begin or had to begin in the beginning of this year in 2023 and has to be reported for the first time in 2024. And other animals will follow. To show you an example of what this use data collection can look like, I will explain to you the German system that was recently built up. So I mentioned before that since 2014 there was a benchmarking system in place for farm animals, and this one was now developed further to meet the new requirements. So to briefly explain it to you, you can see that the veterinarians are the data suppliers, which makes the most sense because they are the ones who treat the animals, and the veterinarians who supply the data of their treatments to a database. In Germany, it is the HITIR database. And this database produces the use data, which is retrieved by my office, the BVL. And it is also our task to report the use data to the European Medicines Agency. We also, out of the use data, produce the treatment frequencies I mentioned before, so that all farmers in Germany can compare themselves to the German standard, you could say, and high-end users can be identified. And if they have very high uses of antibiotics, they can also even get restrictions. So use data is collected from all farm animals since 2023, since this year, of the species cattle, pigs, and poultry. And more animals will follow in the stepwise approach, like, for example, horses, goats, sheep, but also fish and pets, until the year 2029. Then the whole data collection should be complete. This leads me back to our work package about the antimicrobial use data. And of course, we focused our strategic goals according to Article 57. So the main action, which is a joint EMA and HMA action, is to implement use data collection by animal species. And the sub-actions that come out of this are to provide guidance on the transfer of data to national competent authorities, but also on the transfer of the data to the EMA, and to provide guidance on the use of identifiers for respective UPD entries. The sub-actions started already in 2021 when the implementation of the systems started, and will most probably be finished in the end of 2029 when also the reporting is complete. And all of these sub-actions lead to the logical consequence that we have to learn from already established systems in Europe. So most of the participating countries already have data collection systems in place, such as benchmarking systems like we had in Germany, but a lot of countries were also already contributing to the SFAC report. So data collection was already happening. But of course, it has to be fit to the new legislation and to the new instructions in the acts. And I also mentioned to you the UPD connection. So it's also very important to help build up interfaces to the UPD with all the different national databases that are already set in different European countries. So the key question is, or was for us, which systems are already implemented in EU countries and what are lessons learned from this? So the tasks that we were doing over the past 3 years were, for example, exchanging valuable information between us member states. As I mentioned, 5 countries were participating in the work package, and we had a lot of discussions on the different topics. Another important task is the link between EMA and HMA. This is why we started doing like a newsfeed corner with reports from other working groups, because some of us who are members of the work package 1 are also members in EMA working groups. And so again, the information exchange has to be there. What we also did was to report on each other's progress of implementing our own country's national data collection systems. for the sales and use data collection and reporting on the antimicrobial veterinary medicinal products. And we did various presentations of each other's country systems and also our progress. And last but not least, in all of these processes, we shared a lot of experiences and common challenges that we all have to tackle. And to sum it up, I would say we were doing a sharing of good practice examples. I don't want to say best practice examples because, of course, these are all new systems which are working only since this year. And maybe the data quality will not be super strong in the beginning, but I think we all have built up systems that can be good practice examples. Then what I would also show to you is a reflection of the current situation in the work package members' point of view. So to give you the perspectives, but I would also like to stress that, of course, only 5 countries are in the work package. So this represents only the view of the 5 participating countries. And I told you before that the European product database has certain identifiers. And then there are national databases on medicinal products, and a mapping has to be done. And this is a very long list of mapping, because this mapping has to be done not only on the level of a veterinary medicinal product, but also on each product's presentation level. The question was if the data, UPD data mapping is being completed or not. And you can see that 2 countries out of 5 said the mapping is complete, and in 3 countries it is still incomplete. And mainly the mapping of package identifier is still in progress. But all of us helped each other out, or helped out in our country with national identifiers, like a workaround. But what was also said that is the completion rate is already over 90% in most of the cases. Then we also addressed the topic of data quality, and it's again very interesting that 2 countries are already very satisfied with the data quality, and 3 of us said that the quality can still be improved. I mean, it's the first year, there are new systems, as I said, and of course, there are always things to adjust to have a higher data quality. Then we also collected common challenges that I would like to share with you, because I think they are very interesting and might also be helpful for other systems of data collection. And the first thing that we all addressed was the compliance of the veterinarians, because they are the data suppliers. And veterinarians have usually a very hard work day. They have to do documentation a lot, and now they have even more documentation. And it was not easy to address them and to convince them of this new task, but of course it's obligatory by European law. And we helped us with doing campaigns and informative materials for the veterinarians. Then also lack of national legislation was often a problem responding to Article 57, because as you saw, the implementing act on the data formats only came out in 2022 in the beginning, and it was very hard to set up a national legislation in this short time that meets all the requirements of the European legislation. Then, of course, human resources, it's new work to do, and also communication with all the stakeholders is a challenge, as well as improving the usability of the new systems. So with user feedback, you can always do some adjustments that are not ideal in the beginning. And then, of course, another challenge will be next year to do the automated EMA reporting. EMA offers a platform and also templates to be filled in, and ideally those templates would be filled in automatically. And yeah, this also has to be still implemented in some of our countries. And as I mentioned before, the interfaces with the system, the data collection system with the, for example, the UPD, but with other national systems, ideally with veterinary practice management software, is also a challenge that has to be faced. At the end of my presentation, I would like to look into the future with you and our next goals. The goal I was talking about before, we are very deeply involved with the work right now, but in the next years or next year, we will have to work on the other actions as well. And another joint EMA-HMA action is to communicate effectively on the consumption data once it's there. So yeah, to support the publishing and comparison of the use data and establish good quality data in a periodic reporting. And of course, for the countries who have already only implemented the first step, the farm animals, to learn from that for the other species implementation. And the last action is more of an EMA action, but of course, HMA can support, and this is to establish contributions to JIACRA under CVMP guidance and also development processes that maintain member state input and ensure EMA oversight. And I think the last point here, cooperation is key, is a very important sub-action, or I think this is a very important point, and I'm happy that we have this meeting today to bring everyone together and really to cooperate to tackle the problem of antibiotic resistance together. And with this, I come to the end of my presentation. Thank you to let me introduce the veterinary side on this use data collection. And thank you very, very much for your attention. And with this, I come to the end of my presentation. Thank you to let me introduce.
I'm afraid we are going to have some delay effect in the sound with every online connection, so patience. Thank you, Katharina, for your presentation. It's interesting to see how the quality of data is improving by collecting both sales data and use data more close to the use in animals. Now we move on to Dr. Dominique Monet. I introduced him before. He will present us how to collect data from the human side. Dominique, are you online?
Yes, I'm online. Good afternoon from Sweden, and thank you for this invitation. I was not aware of the strategy, so there was a bit of reading, and DC have not been involved in what has happened with the strategy, but that was good reading, and I would say it's good sometime to step on the side and reflect. So if I could have the first slide of a presentation, please. Thank you very much. So reading the European Medicines Agency's network strategy, what we're dealing with now is Objective 2 of Goal 1, foster more robust surveillance systems in the EU for both antimicrobial consumption and emerging of resistance in veterinary and human medicine to foster analysis of the potential relationships between antimicrobial consumption and antimicrobial resistance, and co-selection of antimicrobial resistance by use of biocides and feed additives. I must say that I do not cover, and we don't have a mandate for this, for the last part, the co-selections by use of biocides and feed additives. So we at ECDC, since the start of ECDC back in 2005, I've been integrating existing surveillance system, like for antimicrobial resistance EARS that had become EARSnet. We also implemented more recently a new surveillance system, the European Antimicrobial Resistance Genes Surveillance Network, or EURGENNet, to take into account evolution of the methods for identifying resistance genes and clones. We integrated European surveillance of antimicrobial consumption, that is now under the name of ESACnet at ECDC, and we also integrated surveillance of healthcare-associated infections under the name HINET. Let's start with the ESACnet, our network for surveillance of antimicrobial consumption in humans. So there are reports that are published every year. They were published before under ESAC, and they're now published by ECDC. The report for the past year is available in November of the following year. That means that in November this year, on 17th of November, you'll get the report with the data for 2022. Sorry, the data is available in a dashboard with more detailed data, and I gave you the link for the dashboard here. What we found these past years is after a slow decline of antibiotic consumption in humans until 2019, the last year before the start of the COVID-19 pandemic, there was suddenly a major decrease in antibiotic consumption in the EU, and this is based on mostly sales data. Sometimes countries also deliver reimbursement data, but this is becoming an exception rather than the rule. And most of our data are sales data obtained from the medicines agencies in the member states. So we see a decline, a major decline in 2020 and 2021. And this decline, we were able to show that it was proportional to the size of antibiotic consumption in the country before the pandemic. In other words, it is as if one common event had the same impact on all the countries and the same effect on all the countries, with two notable exceptions: Bulgaria, where antibiotic consumption actually increased during the first year of the COVID pandemic, and Romania, where it basically didn't change. This actually will change. What we've seen in 2022 is a rebound of antibiotic consumption in the EU, and the data will be available, like I said, on 17th of November. And we don't know why there has been a rebound. What we're really concerned about is a general increase in the use of broad spectrum, in quotes, and last resort antibiotics. We have various indicators that are followed by ESACnet, and you see that there have been an increase over time since 2012 until 2021, and even a short-term increase in the recent years since the pandemic, which means although antibiotic consumption is slowly decreasing, the type of antibiotics that are used is more often broad spectrum, and this is of concern. For surveillance of antimicrobial resistance in samples from humans, we have EARSnet, so main surveillance network for antimicrobial resistance. And as for antimicrobial consumption, there is an annual report. The report will be available on 17th of November, but the data for 2022 are already available in our online database. So if you want to already go there, you will get the update from all the member states. And this year, also with the last of the country we're working with and was not participating, that is Liechtenstein. With these data from EARSnet, and these are solid data that go back to 90 something. I mean, this is an old network, and very solid data, I would say. So we've been able to estimate the health burden of infections with antibiotic-resistant bacteria. We had done this already with data from 2015, and we updated for 2016 to 2020. We estimated that more than 800,000 infections with antibiotic-resistant bacteria are diagnosed every year in the EU. They result in 35,000, actually more than 35,000, deaths directly attributable to these infections, and more million of years lost because of disabilities or premature death. I would like to say that more than 70% of the burden is actually linked to healthcare-associated infections. There are community infections. We're not counting the foodborne infections, but the number is very small in the EU compared to those 800,000 infections here. But the burden is really healthcare-associated infections due to these resistant bacteria. The burden remains comparable to that of influenza, tuberculosis, and HIV/AIDS combined on a year without the COVID. And it increased between 2016 and 2020, although there was a small decrease in 2020. Not all countries are the same, and when we control for the size of the population, the disability adjusted life years per 100,000 population on the left, and the number of attributable deaths per 100,000 populations varies widely between countries. And again, this is controlled for the population. This is not because of the size of the country. And some countries at the top of the list have a much larger health burden due to these infections with the resistant bacteria that are listed on the right. I mentioned the EuGenNet, our European antimicrobial resistance gene surveillance network that has the aim to do genomic-based surveillance of multi-drug resistant pathogen of public health importance. This is mainly targeting Klebsiella pneumoniae and Escherichia coli, and we now are considering expanding to Acinetobacter baumannii and possibly Pseudomonas aeruginosa. And what we've been able to do with this is to identify the spread of certain resistant bacteria. For example, E. coli isolates that are carrying the carbapenemase gene, New Delhi metallobetylactamase 5. Increasing frequency of detection since 2012, the predominance of certain sequence types that we consider as clone of a higher risk of spread as compared to other clones. About 1/3 of the isolates were associated with infections. The others were carriage, identified through screening, and more than half, because of the genes that were found through the whole genome sequencing, were predicted as being multi-drug resistant. Even without this, if the E. coli isolates are carrying a gene encoding for a New Delhi metallobetylactamase, they're resistant to multiple beta-lactams, including carbapenems. There is also surveillance of resistance in Salmonella and Campylobacter, foodborne pathogens, as well as in food-producing animals, indicator E. coli. And this is done jointly under an EU legislation and published every year in the European Union Summary Report on Antimicrobial Resistance in Zoonotic and Indicator Bacteria from humans, animals, and food. This is done jointly with EFSA. And I'm just highlighting one example, but it's a result of what is happening with antimicrobial consumption in food-producing animals in the EU and the large reductions that we've seen over the past years. Not only there is a north-south gradient in the level of E. coli isolates, commensal E. coli isolate from broiler chickens, that have complete susceptibility to all tested antimicrobial classes. that this percentage of complete susceptibility is increasing from 1 year to the next. So there's a decreasing trend in antimicrobial consumption in food-producing animals and an increasing trend in complete susceptibility of the isolates found in broiler chicken. And this is encouraging, and I hope we'll have more results in the coming month. So many surveillance systems. So the European Commission asked the agencies, the three agencies, ECDC, EFSA, and EMA, to work together. And the last mandate that we received was in January 2022 to work together towards, which is now a fourth report on an integrated analysis of all our surveillance data. The report is due December 2023, as per the deadline that has been given to the agencies by the European Commission. And we will be able to respect this deadline with an update on data pertaining to 2019 to 2021. I wanted to a few results. For example, we have a method, maybe it's not the best method, but we've devised a method to compare antimicrobial consumption in humans and antimicrobial consumption in food-producing animals. And the way to do this is to control for the kilogram of estimated biomass. The biomass is population correction unit for food-producing animals, that is slaughtered food-producing animals, and an estimation of the biomass of living humans in the member states. That's the method that we have so far. May not be the best method. We may have to devise another method, but it's definitely better than just comparing tons or kilograms. And we confirm the decrease in antibody consumption in food-producing animals. And actually, with this metric, we see a small increase in consumption in humans. The level of antimicrobial consumption in animals and in humans is quite different, and the variation is also very different. While there's a variation of more than 100 between the country that uses the least antimicrobials in animals and the country that uses the most, the variation is only about 6 times when it comes to humans. And this is shown on this graph, but again, the metric would need to be reconsidered because after using it for now, I would say 10 years, we're not sure that is the best metric, and we may use a better metric for comparing food-producing animals and humans. So can we assess the relationship between all these data? At ECDC, we tend to consider antimicrobial resistance and antimicrobial consumption in our society as a pathway. We raise animal, we produce food in farms, and we may use antibiotics in these two applications, and that may result in bacteria that have developed or select bacteria with resistance, for example, E. coli. We eat the food that is produced, and we may be colonized by the bacteria from this food. In addition, we, the population, may be prescribed antibiotics for an infection that may select from the bacteria from food, that may select from other bacteria. If we really get unlucky, some of us, a small proportion, will be hospitalized. But the risk of receiving an antibiotic in a hospital, and especially in the specialized units such as intensive care units or oncohematology unit, increases a lot. And there's more risk for selecting antimicrobial resistance. We know that patients transferred from hospitals in countries that are not EU member states, sometimes in other parts of the world, bear the risk of carrying multi-drug resistant bacteria, and these should be screened and isolated. We know also that people that have traveled without contact with healthcare are also at risk of carrying multi-drug resistant bacteria, for example, multi-drug resistant E. coli. But this is our view of how we should consider things. So if we make correlations, we should be careful about which antimicrobial consumption try to correlate with which antimicrobial resistance rate from which source. And that's what we try to show here. Salmonella and Campylobacter are extremely rarely responsible for healthcare-associated infections in hospitals at the top of the graph. But there is a pathway from, like I explained, from food animals to food and to humans. Streptococcus pneumoniae, Streptococcus pyogenes, or group A Streptococcus, are bacteria that we do not acquire from animals. They are very rarely, never responsible for healthcare-associated infections. They really represent community infections. E. coli is a pathogen that is somewhere across the various compartments. I mentioned E. coli from food sources. E. coli are responsible for many community-acquired infections and sometimes not the most frequent for healthcare-associated infections. And then we have the common healthcare pathogens that we don't acquire from food as per current knowledge, that are rarely responsible for community infections, but are mostly responsible for healthcare-associated infections. Now that I put this preamble forward, let's look at the correlation. So let's start with community. On this graph on the left, and I'm using data from EARSnet and from ESACnet, we have community consumption of macrolide, lincosamides, and streptogramins. They're mostly macrolides control for population. And on the y-axis, the percentage of Streptococcus pneumoniae, a pathogen commonly responsible for community infections, that are macrolide resistant. And you see a nice correlation. The more a country uses macrolides and alike antibiotics, the higher a percentage of resistance. If I move to the right graph, and I switch gear, I take community consumption of quinolones in the member states and the percentage of E. coli that are resistant to fluoroquinolones. And you see also a nice correlation. Most of the consumed quinolones are actually fluoroquinolones. And there are multiple publications showing similar correlation. But this is for the community. If we move to hospitals and we have data from our regular point prevalence surveys, infections and antimicrobial use in European acute care hospitals, and this is from the latest published report from 2016-2017. The next report with data from 2022-2023 is due May next year. So we see that the higher the proportion of patients on the day of a survey that received at least one antibiotic, the higher the percentage of resistance as per a composite index of resistance in various bacteria responsible for healthcare-associated infections. These are selected for healthcare-associated infections. And each dot corresponds to a country in the database. Inversely, the percentage of antibiotic prescriptions that were reviewed and changed, either for stopping the prescription, let's say a prolonged prophylaxis that didn't need to be, or for de-escalating, because microbiology results have been made available, and there's reason to de-escalate and move from broad spectrum to a more narrow spectrum antibiotic, or possibly escalate because the situation of the patient is deteriorating and possibly there is proof that there's a multi-drug resistant pathogen involved. All these, the percentage of all these actions among all antibiotic prescription actually results in less resistance. In other words, antimicrobial stewardship, increased antimicrobial stewardship results in less antimicrobial resistance, we'll have an update of this data in May next year. Finally, when we look as part of our third chakra report about the relationship for, let's say, fluoroquinolone-resistant Campylobacter jejuni and fluoroquinolone consumption. In green, we have fluoroquinolone consumption in food-producing animals, in blue in humans. In yellow, we have resistance in Campylobacter jejuni isolates from animals. And in red, we have resistance in Campylobacter jejuni infections in humans. We see that there's a link, as per the model that was published in the report, between fluoroquinolone consumption in animals, fluoroquinolone resistance in Campylobacter jejuni from animals, fluoroquinolone resistance in Campylobacter jejuni from humans. Well, not a surprise. We're dealing with a foodborne pathogen, but there's no link with fluoroquinolone consumption in humans. Personally, when we deal with E. coli, which is the best One Health pathogen, we see that both fluoroquinolone consumption in food-producing animals and fluoroquinolone consumption in humans actually impact the percentage of fluoroquinolone resistance in E. coli. And there will be more of such models and correlations in the upcoming Chakra 4 report. On 13th of June, the Ministers of Health of the Council adopted Council recommendation on stepping up EU actions to combat antimicrobial resistance in a One Health approach. And these have 2 points that I picked up that I think are relevant for our discussions today. The first one is about surveillance and monitoring of antimicrobial resistance and antimicrobial consumption. I'm jumping upon all the points that we need to work at ECDC together with member states to improve surveillance of antimicrobial resistance. But the points that are relevant for Medicines Agency is the collection of data on antimicrobial consumption in humans at the appropriate level to allow the monitoring of antimicrobial prescribing. We're not talking sales, we're talking prescribing, to provide timely feedback on prescription trends and patterns involving, among others, prescribers, pharmacists, and other parties collecting such data, and where possible, and appropriate using EU-level digital infrastructure. And then developing integrated system for the surveillance of antimicrobial resistance, consumption, encompassing human health, animal health, plant health, food, wastewater, and the environment. So this is something new that we will need to work on one way or the other. The second is recommended targets for antimicrobial consumption and antimicrobial resistance. I will not highlight the targets on antimicrobial resistance, but there are targets for antimicrobial consumption based on sales data and expressed in defined daily dose per 1,000 inhabitants per day, ensuring that by 2030, the total consumption of antibiotics in humans is reduced by 20% as compared to baseline year 2019, and that by 2030, at least 65% of the total consumption of antibiotics in humans belongs to the access group of antibiotics. So we at EC, that puts some responsibility on the EU, obviously on member states to take action, but also on ECDC, because we need to monitor the progress towards the target. So in this slide, I put the data that are available so far and the highlighted baseline year 2019. There have been, like I said, a large decrease in antibody consumption in 2020 and 2021. So it would look like the EU is actually approaching its target that was supposed to be the target for 2030. But there's been a rebound in 2022. So wait for our update of data on 17th of November, and hopefully we'll have some explanation for the rebound from our contacts in member states. About the other indicator, there are very few member states that actually have 60% of more of antibiotic in the access group, and there have been little change over time in the past years. As I told you, the trend is more moving toward broad spectrum antibiotics, that is antibiotics in the other category classification, watch and reserve, and this is definitely something that we will need to work on. The targets on antimicrobial resistance are an estimate of the incidence of bloodstream infections for 3 resistant pathogens. These were devised and estimated for the work on the targets. They were published for the first time last spring, but we'll have an update of the data again on 17th of November. So there are a few limitations, and like I said, I thank you for allowing us at ECDC to reflect on what we're doing. And I wanted to highlight a few limitations. So on antimicrobial consumption, can we really compare antimicrobial consumption in humans and food-producing animals? I mentioned this, and this is a reflection that is currently taking care under the JACRA collaboration, but we may need to find other metrics for this comparison. Second point, what are the reasons for recent changes in antimicrobial consumption in humans? At EU level, the data cannot be stratified by sex, age group, and shorter time periods other than a year. The data on the numbers of prescriptions are not available. We know that some member states have access to those data, but we don't have those data from all member states, which means we cannot have an EU indicator, and we cannot offer for the member states to benchmark each other on the number of prescriptions for the various groups of antibiotics. And finally, the indications for the prescriptions are not available, and this would be really needed to understand the large decrease in antibiotic consumption in 2020, 2021, and then the rebound in 2022. Is the rebound because we just behave as we did before COVID? Or is the rebound because there are new types of infections? Is the rebound because of shortages that would require prescriptions, for example, of macrolides, because there's a rebound in macrolide consumption in several member states, instead of penicillins? We don't know. For antimicrobial resistance, our data so far focus on invasive isolates, that is mostly blood. But what about other types of infection? And what about carriers? There are provisions in the Council recommendations for the EU to work towards improving the surveillance towards other types of infection, and we'll need to work with this. Information is mostly not available for the status of the patient, of the infection. Is the infection healthcare associated or community acquired? This is a variable that is often empty in our databases. Similarly, there is no information about recent hospitalization in the country or abroad, or recent travel outside of the EU. And we know these are risk factors. And finally, the incidences of bloodstream infections with resistant bacteria are estimates, and we'll need to assess over time if these estimates represent reality, but they are what we have for the time being, and great progress has been made by colleagues at ECDC to devise those estimates, and they are approved by the network members and by member states. So I will finish here. You saw that a lot of data will be available on 17th of November, and then by the end of the year for JACRA. So there's watch this space. There's a lot coming from ECDC. Thank you very much.
Thank you very much, Dominique. As we have run out of time, I think that we have to move to the next session and to leave the questions for the end of the following session. Please keep them in mind, because we will come back to questions. So the next session is about diagnostics tests, diagnostic tools against antimicrobial resistance. And for this topic, we count on Sultan Kunsagi. He's head of service veterinary antimicrobial resistance at the European Medicine Agency. He provides support to the Committee for Veterinary Medicinal Products Working Party. He's the main contributor from European Medicine Agencies to the JACRA. Then Budegin Katri, who is part of also the Working Party on AMR, which gives support to the Committee of Veterinary and Medicinal Products, a decision-maker committee at the EMA. Then Radu Botros, he's a senior scientific officer from the EMA. And finally, Olman Elizondo, who will give us a different perspective. He's a project manager of the Proyecto Radar PPI. He's joining us in the table from the HTA agency of Catalonia, Aquas. And this is an important project to provide this kind of diagnostic tools that are not always in the market. So without any further delay, please, Sultan, you have the floor.
Thank you very much. Good morning, everyone. And greetings from Amsterdam, from the European Medicines Agency. This is a very interesting session, and I'm really happy that I'm here with three excellent speakers. So during this 1 hour, we would like to focus on the AMR diagnostic tools. And first, I would like to give a brief introduction what we are doing currently regarding this topic at the Veterinary Medicines Division. And after that, I will give the floor to my colleague, Radu, who will talk about the human perspective. Then Budven will summarize the situation in Belgium on the diagnosis and treatments. And then Olman, who is actually with you in the audience, will summarize a collaborative intervention against AMR through public procurement of innovation. So I hope you can see. Yes, you can see my slides. Again, so these three experts were already introduced, so I will skip these slides. And I would like to just start my brief introduction with facts, basically that the diagnostic tool is the main requirements for the responsible use of antimicrobials, is an accurate diagnosis before treatment. And this is considered to be really a gold standard of good veterinary practice, aiming to move away from empirical towards substantiated therapy. This morning, Thomas and Barbara were already talking about a concept paper which is currently out for consultation. Next year, the CVMP, the Committee for Veterinary Medicinal Products Working Party, AWP, the Antimicrobials Working Party, will work on a reflection paper on the availability and characteristics of diagnostic tests to improve the responsible use of antibiotics in animals. So this will be a reflection paper which will be also out for consultation, and I think this will be really interesting. So that's why we would like to advertise this a little bit. And how we work is that before we publish any reflection paper, we publish a concept paper to basically collect comments, advice from stakeholders. The CVMP's AWP finalized and published after the adoption of CVMP this concept paper in July, and this concept paper is still out for consultation until the end of this month. The diagnostic tools, the importance, well, is quite obvious, but on the left part of the slide, I just wanted to summarize that it is mentioned in the CVMP's work plan currently. It is also mentioned in the CVMP strategy on antimicrobials 21-25, but also there is reference to it on the European Medicines Agency's network strategy to 2025 and the European Medicines Agency's regulatory science strategy. And before I give the floor to the first speaker, I just would like to summarize what we expect from the impact of this reflection paper. So this reflection paper will obviously provide information on reliability of currently available diagnostic tests and information on future tests for the confirmation of infections with either antibiotic susceptible or resistant bacteria. This will support the responsible and targeted use of antibiotic agents by veterinarians. It will, of course, facilitate the One Health mitigation process to combat antimicrobial drug resistance as outlined by the international and European dedicated health organizations. And additionally, where appropriate, identification of the lack of diagnostic tests can encourage further development of such tests. So again, this was a quick advertisement of our currently published concept paper. Feel free to send any comments. And now I would like to give the floor, apologies, to my colleague here at the agency, Radu Botgros, who is a senior scientific officer and, as it was mentioned, infectious disease specialist. Radu, please, the floor is yours. Thank you. Are you connected, Radu? Apologies, can you hear me?
Is there Radu connected? No, he's not connected.
I just would like to ask the organizers if they can hear me or.
Yes, Sultan, we can hear you, but we are asking our technical support team if Radu is connected, and it seems he's not.
Okay. Maybe we can move to Budven's presentation because I saw him that he was connected, and in the meantime we could send an email to Radu if you agree.
Perfect.
Radu just mentioned that he's here.
Okay, we can see Radu around. Okay.
Apologies, Radu. Then I just go back to your presentation.
Can you hear me now?
Yes, we can hear you. Thank you.
I was in the backstage according to the system, so obviously I could not speak, but I could hear and see you. So I was saying that I would like to thank you very much to the organizer for having invited me to speak in this what I believe is a very important meeting, and I have been able to watch it from the very beginning, having heard all the presentations from the previous speakers. I think this is a good forum to indeed inform ourselves and try to move things forward. And what I will be talking today is about diagnostic tests that improve the responsible use of antibiotics, and obviously what the EMA can do, what is within our remit to do about that. So if I can have the slides, I had them at some point, and now I see only myself on screen. Can you see the slides in the room?
No, not yet.
Hello?
Yes, Radu, we can hear you, but we cannot see your slides. Are you sharing your slides?
Not really. Zoltan, can you share the slides? They were on screen before. There you go. Can I have the next slide, please? So I was about to say, I was saying that indeed, as we all know, there is a critical need to have new accurate diagnostics helping us in the fight against AMR. And obviously, I think there are multiple reasons for that, from surveillance to indeed stewardship, which is probably more closer to what we do at the EMA, because obviously we approve medicines as our main role. And the whole point of needing new diagnostics is recognized since quite a while now, at least a decade. And as you know, there have been a number of groups that have tried to foster innovation, starting from the Longitude Prize, but also other such attempts to foster innovation and also market entry and access. And you know, at the time when for instance Longitude Prize, and you see here the advertisement from 2014, was launching these support measures, the aim was to incentivize point of care diagnostics that could distinguish between a bacterial and a viral infection. Nowadays, you know, the expectations are higher, and so we expect from such a test to identify the pathogen, to suggest the effective antibiotic, and even some of them to determine infection severity. And so one of the important bits is that apart from innovation, there is this financial aspect of the whole story. Obviously, I'm not in the best position to talk about finances, but I think we need to also reflect upon investment in this area, you know, pricing of such diagnostics, return on investment for those that develop them. Next slide, please. And in order to explain what we are doing at the EMA on the human side, I thought that it would be useful to reflect a little bit as to what the legislation is saying about our remit and the remit of the regulatory network of the European Union on those tests. You see on these slides that we actually have two main regulations. One is the regulation on medical devices, which is 2017/745, in which what is defined is what a medical device is. And actually, it's a product or equipment which is intended for a medical purpose. So this, you know, can be a large variety of things. It's not only diagnostics, obviously. Now, all the medical devices must undergo a conformity assessment, as you well know, which actually is aiming at demonstrating that they meet the legal requirements to ensure that they are safe and that they perform as intended. Now, IVD, which is in vitro diagnostics, are also medical devices. They are, you know, they are governed by another regulation, Regulation 746 from 2017, and they, as medical devices, must also undergo the conformity assessment. Now, the whole process is regulated at the level of the member states of the European Union, but the EMA is consulted in the regulatory process, and you will see that there are different situations and different remits for the EMA for this. You know that you know, there are member states that designate, I mean, all member states designate notified bodies to conduct these conformity assessments. And the conformity assessment usually involves the audit of the manufacturer's quality system. And then, depending on which kind of a device it is, a review of the technical documentation from the manufacturer on safety and performance of that device. And as a final point, the manufacturers can place CE, which is an abbreviation of Communautaire Européenne mark on a medical device once it passes this conformity assessment. Next slide, please. As I was saying, there are different situations. You know, the one that is totally in the remit of the EMA is that one in which a medicine is used in a combination with a medical device. In that case, we assess the safety and effectiveness of the medicine used in combination with the medical device, and the assessment is part of the marketing authorization application for the medicinal products. So there we have, you know, a very well-defined role and remit. Now, I won't go through all of this. I will try to highlight, in the interest of time, the situations which I think are more relevant to the discussion on AMR and diagnostics for AMR. So the second one, which is important, is the issue of companion diagnostics, where the notified bodies must seek the EMA scientific opinion on the suitability of the companion diagnostic if the medicinal product with which it is used in combination falls within the scope of the centralized procedure. And one last point is that for high-risk medical devices, the EMA supports the expert panels which provide opinions and views to notified bodies in these kind of situations on the scientific assessment and in vitro diagnostics. Next slide, please. I thought it would be useful also to reflect a little bit upon the definition of the companion diagnostic as such. This is obviously coming from the regulation 746. And actually, what it says is that if an in vitro device is used as a device to screen patients eligible for treatment, or those patients in which the drug should be contraindicated, so this is essentially a companion diagnostic. The remit is for the EMA or an EU national competent authority that should be consulted as part of the CE marking process that I described previously. You see on the right-hand side of the slide that the diagnostic should be essential for the safe and effective use of a corresponding medicinal product to either identify before and during treatment those patients that are most likely to benefit from the corresponding medicinal product, or patients likely to be at increased risk of serious adverse reaction as a result of the treatment. Next slide, please. The whole process for consultation is defined also in the legislation, and the scientific opinion, which can be given either by the competent authorities of the member states or by the EMA regarding the suitability of the device in relation to the medicinal product, is supposed to be provided within 60 days of the receipt of the documentation. And this 60-day period may be extended once for a further 60 days on justified grounds. Next slide, please. There is also another situation in which our remit as regulators is more limited, I would say. So there are those situations in which you have a diagnostic test that is developed to be used in combination with a medicinal product, but it does not fall under the definition of a companion diagnostic. And in those cases, we have, for instance, for infections, biomarkers that are used to adjust the posology of the medicinal products. And I think there are a number of them already out on the market and which are used by clinicians. Now, in these kind of cases, EMA could still request information about the biomarker during the evaluation of the medicinal product, and it could decide to make specific recommendations in the product information, but there is no consultation of the EMA as part of the CE marking of the in vitro diagnostic. Next slide, please. I put this for your information. It's actually a classification of in vitro diagnostic devices according to Regulation 746. I won't be reading all of these things on your screens now, but I think the one that I would like to point your attention to is the first category on the left-hand side of the slide, because there we are talking about IVD devices which may detect the presence of the exposure to transmissible agents in blood, blood component cells, tissue, or organs, or exposure to transmissible agent causing an life-threatening disease. Now you see that according to the regulation, these tests are considered as category D devices, high risk devices, which, as I mentioned before, could benefit from the opinion of the expert panels which are set up at the EMA. And I'm saying this, next slide, please, because we have we obviously, you will have understood from my previous explanations that our remit as regulators, and I'm talking here EMA, but also the whole regulatory network of the European Union, the remit that we have and in regulating diagnostics varies on the situation. And obviously, we recognize the importance, the utter importance of progressing the matter or helping to progress the matter, and this is probably why we are all here today. So one idea could be to consider AMR relevant diagnostics as Class D IVDs, despite you will have seen that not all of them actually truly qualify into that category. So if we would do such a thing, obviously we could use the expert panels that we have at the EMA and would be involved in the consultation. So that could be something that could be discussed. You need to know that EMA is currently running a pilot that enables the expert panels to provide scientific advice for manufacturers of high-risk medical devices. And there are 3 prioritization criteria that you see on the right-hand side of the slide. The second one obviously addresses devices that help address an unmet medical need, and obviously conditions that are life-threatening or that can cause permanent impairment. And I personally believe that actually many of the AMR relevant diagnostics could fall into that category as well. Next slide, please. Last but not least, there are situations we have at the EMA a group of early interaction with developers. It's focused mostly on medicines, but obviously it also covers borderline products and also substances that are incorporated in medical devices for which the medicinal and ancillary functions are borderline. This group actually is an early interaction with a network of developers of either borderline products or the others that are incorporated in medical devices, as I said. The group is set up to provide advice on scientific, regulatory, and legal aspects, and is set up to ensure coordination and to provide a forum for this early dialogue. So I think another idea could be to use in those situations that apply this group to indeed have initial discussions with developers and trying to help them navigating the system and understanding the requirements that are needed for approval of those devices and diagnostics. I think this was my last slide. If you can check. Yes, indeed. I would like to thank you very much again for inviting me, and looking forward to questions, if any, and obviously to the discussions that will follow. Thank you very much.
I
I guess Boudin is connected.
Yes, indeed.
Yes,
Hello,
please.
everybody.
The floor is yours. We'll leave the questions for the end of the session.
Thank you very much. Thanks also for the invitation, dear President, dear colleagues. I hope my slides will be shared by my dear colleague Zoltan. And the first slide normally should directly show what I would like to share with you. In particular, the situation in Belgium on diagnosis and treatments. And when I say that, I would refer in particular to the different situations. So I will run through some resistance issues in Belgium, then some consumption situations, first community hospitals, and last but not least, the nursing homes. And then I would end up with what Dominique Monet already mentioned, the point prevalence surveys that are used also in Belgium widely. So actually, in Belgium, the situation in red is similar to what is seen in many European countries. So in red, you see the most famous nosocomial infection, Staphylococcus aureus, which is resistant to methicillin. Because of hand hygiene campaigns, because of antibiotics that can be applied topically, because of shampoo, movement of clothes, the organism is more and more defeated. In contrast, in the blue and in green, you see organisms that are more and more upcoming. And it's not by accident that they are found in the digestive tract. So E. coli and Klebsiella. So that is a tendency that is for years now seen in many countries in Europe. Next slide, please. So this is a slide, previous slide was until 2015. This is the most recent evolution. And then again, you see for Staphylococcus aureus, our EARS data, we call them EARS-B because we also include urinary tract infections. We see a smooth tendency. So actually MRSA is no longer the big problem compared to the beginning of this century. Next slide, please. Yeah, that are the next slide, please. Sorry, that is the last pictures from 2022. What we see is not only E. coli, gram-negative, but also gram-positive digestive tract bacteria like enterococci, and sometimes they're resistant for a last line antibiotic, which is called vancomycin. You see, and then I just would refer to the first line and the first two lines, the number of outbreaks reporting in our surveillances on that particular bacteria. You see it's 7.5, 9.3, 7.4, a little bit higher in 17 and 18, and then it drops again in 2020. But anyway, a lot of hospitals have, even for this only digestive tract organism, a lot of outbreaks. So in my humble opinion, when diagnostics need to be innovated, one must try to have a fast clonal relationship between different organisms. For the moment, we rely sometimes on procedures that take 2 weeks. Thank you. Next slide. One of the organisms which was initially not covered by the Belgian surveillance systems, but the last 10 years that is Pseudomonas, but also Acinetobacter. And in particular for Acinetobacter, you will see, it's not clear, but it is in orange, a steadily increase of carbapenems. And I will show that the carbapenems, as Dominique also showed for the European level, is increasing not only the use, but also the resistance in Belgium. And Pseudomonas, in my humble opinion, that is more of a concern. You see that they are all originated from blood isolates. So that is something we need to consider in the future. Good and fast diagnostics. Next slide, please. Next. Yes, so also the last data are demonstrating what I have seen. Yes, next slide, please. Here you see more in particular the same information. So carbapenem, which is a last line agent for, in particular, gram-negative bacteria. And here you see for Pseudomonas, again, the difference between resistance in labs originating from hospitals and outpatient labs. So in dark green, there's a situation in hospitals, and the outpatient is indicated in pale green. Remarkably, during the pandemic, we see an increase. We are making some statistical analysis, but we think that it is at least abundantly present, and this might be, by what Dominic Monet says, changing in antimicrobial consumption during the pandemic. Next slide, please. So, I'm sorry, this was what we have seen in the resistance situation. Before I go into the consumption, one final slide on the resistance, namely Streptococcus pneumonia. We also call them pneumococci. They are largely originating from the community. And we see actually not a real trend, despite maybe the last few years, and in particular, the penicillin non-susceptibility in brown is an artifact. And that's that's explained below, but that is because the interpretation criteria in the lab were modified. So take care when you see fluctuations in resistance that either the method or the interpretation has not changed. But again, the community for Streptococcus pneumonia, more than 90%, and that's the green line that you see, more than 90% still is susceptible for penicillin. As Dominic Monet pointed out, the availability of penicillin can be a problem and an issue. Thank you. Next slide. This, well, I will skip because Dominic Monet already showed. Next slide, please. This is a situation in Belgium where we would, in particular, say what our target is in red by 2024 and what the European mean is. So we also have seen the rebound effect in 22, but the data are still in the system of ASAC, and they will be launched in November. But very important, there have been changes. And the next slide, please, shows what in the hospitals in particular might have been ongoing. So what you see is a modification of macrolides, here presented by azithromycin. Remember that in the first year of the pandemic, sometimes it was advised, in contrast to the later evidence, to use that for COVID. The same for antimicrobials that can be used for Pseudomonas and so on. Vancomycin, which is important for gram-positive bacteria like Enterococci. And then the third generation cephalosporins, they also increased a little bit. On the bottom, you see, by contrast, not the individual oration, but overall, the antimicrobial consumption in Belgium did not, in hospitals, largely was fluctuated. Next slide, please. When we then compare community and hospitals, so where would we focus for the future our diagnostics on? This is a slide that might result maybe in a bias. And I would like to explain. At your left, you see the consumption of antimicrobials in the community, and it is expressed per 1,000 inhabitants per day. It's called a DID for people that work on that on a regular basis. You see that Belgium is approximately, thank you, Zoltan. It's in the bottom, more in the bottom. By contrast, in the hospitals at your right, you see that Belgium is doing a little bit better. But my big concern is, because I agree with the left indicator being the DDD expressed by a good denominator in the community inhabitants. On your right side, I do not agree that for hospitals, the denominator is inhabitants. Because if we take a good denominator in hospitals, it should be the number of patients in there. And then in contrast with what you see now at your right, with a variable 1.5, maybe 2 per 1,000 inhabitants. Next slide, please. You see, next slide, please. Yes, you see here from left to right for consecutive years, the amount of daily doses, DDD, per 1,000 patient days. And so instead of only 1.5 or 2 per 1,000 inhabitants in hospitals, actually the selection pressure is 500 over 1,000. You can also express this in admission at your right, but now let's stick to the patient days. Next slide, please. I also do the same exercise, again, left, expressed by the patient days, and on your right side by admissions, to compare with the other countries. And so the Belgian situation is not that worse in blue, but you see that even an increase for that period, the data are a little bit older and the data are not readily available. That's why you see some missing data. But you see that also in other countries, approximately 500 out of 1,000 patients receive an antimicrobial in the hospital. Again, a plea to consider that diagnostics and treatments really should be modified or improved there. Next slide, please. Just to show you that we have an increase of healthcare-associated infections. This is bloodstream infections during the pandemic. Many countries have seen that, not all of them. Next slide, please. And this is a situation in nursing homes. At your left, I again try to express with a good denominator the use in nursing homes. And here we have per 1,000 beneficiaries, and that are the residents. In the dotted line, you see outside the nursing homes. So that refers to the slide that you have seen, the DID, the days per 1,000 inhabitants per day. And you see that it's around 30, maybe 25 per 1,000 now in Belgium. But in contracts in nursing homes, it is the triple or maybe the 4 times bigger. And remember that at your right, you see a lot of casualties were in the nursing homes. Next slide, please. So now I would like to end with a recent picture of the point prevalence survey. So in contrast to the evolutions that you have seen that are yearly followed up, sometimes we do a cross-sectional study like the point prevalence survey. And here you see preliminary data because and that's mentioned below, the long-term care facility associated infections are still around. But what I want to mention is the second line, that pneumonia and COVID is among the healthcare associated infections, whereas before the pandemic, we did not measure them. So targeted syndromic surveillance must integrate or must include N bacteria, but also other organisms like COVID. Next slide, please. And I want to stress that it's not only COVID. On the bottom line, you see SARS and blue, but also the Candida and the Aspergillus. Candida a little bit above that, that slide. You see that Candida actually with 4.1% exceeds the number of MRSA in Belgium. You see also that bloodstream infections is a lot of evolved. So fast diagnostics that have a wide variety, both bacteria, viruses, and mycosis is the future. Next slide, please. That was just to mention where we were in the pandemic. So it was not a lot of people on ventilator, but a lot of people still having COVID. And I think that is my last slide indeed. And thank all my colleagues and you for the attention. Thank you very much.
Thank you, Bodin. And now to end this table, we have the presentation by Olman Elizondo.
Yep.
I think so. Try.
Yeah, okay.
Try again. Okay.
Thank you. So thank you for the organizers for inviting us to this important meeting, and thank you to the table. And first, what I'm going to present, the RAVA PPI, which is a collaborative intervention that is already a EU-funded project, a vehicle in which the EU is already trying to see how to promote innovative solutions for the MR problem. And why are we here? It's first an important question in terms of ACUAS, which is the public body, the health technology agency from Catalonia, and our history in terms of using procurement of innovation as a vehicle has been also parallel to the EU use of this vehicle as a strategic element for boosting demand-driven adoption of innovation. So there are a few steps that are important here. For example, in 2012, we were the first coordinators of the first European PCP project, which PCP is a pre-commercial procurement, which requires still, let's say, the probable solution for our unmet need is way ahead the horizon. So we need by the development process itself, and the solution itself is a pilot of that unmet need. Second, in 2014, we did the first public procurement of innovation already with EU funds, which was called Stop and Go, and it was executed at local level in Catalonia. Then in 2016, we had the first cross-border PPI, which was Ritmo Core, and we also had the first time a project targeting AMR, which was a PCP called Anti-Superbugs. And Anti-Superbugs, as you'll see, is sort of the father of Radar project in which we're at right now. So that's 2016 already. In 2018, we already organized within the Catalan health system a first process from the payer's perspective of using procurement innovation to boost this demand-driven vehicle. On 2020 and 2021, two PCP projects that are already using a methodology that is permeable to value, in which we understand that the stakeholders from the demand side have different perspectives of what value represents and how you introduce that in a value-based procurement procedure were already used here. 2022 is the year in which we launched Radar as a follow-up PPI, in this case, of public procurement innovation, following up from the anti-superbugs results from the COVID-19 evolution as well. Then we have also in 2022 three projects, Can Heal, Harmonix, and SafeCore, which we, in this point, we sort of reversed this value-based methodology that we were using to procure innovative solutions, but we used this then to assess the maturity of innovative solutions that come from the market and try to see what are the elements that from the public body's perspective are needed for them to be adopted. And in 2023, we had a set of policy making using procurement and innovation, in which we had a set of transformative projects using the next generation funds that are part of a global holistic strategy to aim for the long-term transformation of the system, in which they have to use procurement and innovation also to do this. And the ninth element is the knowledge generation that we've built upon these years with community practice, like PP or URIFI, and then also education projects like UpRates and iRates that are targeting the health professionals. We have received a couple of awards, for example, in terms of the European Innovation Council on 22. They gave an award of the strategy we used for procurement of innovation in Ritmo Core project. And just recently, we were awarded the Amparo POG award for procurement of innovation for the iRates program. So what is the rather value-based procurement? Basically, you know, we've discussed here the problem of AMR. It's around 5 million people died of something related with AMR, and approximately 1.3 direct results from AMR. There will be more deaths in 2050 from AMR than from cancer. There's a high economic burden, around 1.5 million in terms of healthcare costs and the productivity losses. And the way in which we're treating infections are endangering our own health processes and the way we solve problems today. So what's the need in this term for Radar is to respond to this joint action of the antimicrobial resistance, the JMRA, in an action plan in elements like improving the detection systems to ensure the quality care process, the screen drug resistance and virulence to improve treatment effectiveness, to reduce the health cost and governmental cost, and reporting rapid communication of increased resilience, right? And here we have the COVID-19 example on how all of these elements were also not just addressed, but we had to deal with, and this sort of provoked a new set of circumstances in which we're at right now that Oh, I know what I did. Yeah, here we go. So adding from the anti-superbug results, in which we had a different set of buyers, and adding on the COVID-19 circumstances, we have the RIDER project. So in RIDER, we're a consortium of some 4 different buyers. We have RESA as a central purchasing body from France. We have the Basque country of Sakidetza buying for the Basque region, the Catalan Institute of Oncology for Spain, and University of Naples, Federico II, which is a public health department in Italy. We also have supporting entities in which Aquas is the coordinator, INSERM, which is the coordinator of the JAMRAI, the first one and the second one, INSME in Italy, which is SME organization, JIRA, which has a lot of experience in procurement of innovation, and Bio Gipuzkoa region in Spain. So they're all supporting the different buyers, and we're all collaborative working towards the same target. So in terms of the buyer groups, we have the Basque country, which is not only targeting this from a buyer, let's say the health system perspective, but they're also targeting the primary care. So it's an interesting mix of buyers because, for example, in the Catalan case, the Catalan Institute of Oncology have patients that are immunodepressive in which AMR becomes a more serious threat. And they also have BINCAT, which is the surveillance system for the whole Catalan region. We have France as a central purchasing body addressing the entire French country as possible buyers. And Federico II provides also for the whole Campania region in terms of public health, right? So we have 4 different buyers. And in the way in which we do this, we go from the needs to the definition of the call for tenders and a methodology in which we first start with the demand need and the need desirability assessment, in which first we identify what the problem is and the needs elicitation, and then we do a needs verification and requirements. And we also present a business case, because the business case is quite a strategic element in terms of how is the intervention of what we're trying to change different from the status quo of what we're at. And this is what it's going to provide also not just the public side, but also the economic operators, the incentive to see how this might have different impact in the future versus what we do now. Then we have a second element, which is the market maturity, in which we do a state-of-the-art analysis. We see what's out there that could have a possible solution for our problem. And then we do an open market consultation to actually see what the market is offering that could apply to the unmet need that we're trying to face. And a third element is the demand feasibility and viability assessment, in which we prepare the procurement, and we prepare also a contract permeable to value, which means that we define the elements that are important for us in terms of the impact and the outcomes. And from here, we also do this in terms of sharing risk with the suppliers and defining it, maybe a new governance through them. And we do, in this case, public procurement and innovation, but there are other vehicles that may be chosen. But for us, in this case, public procurement and innovation is important. So we take a multidisciplinary approach. This is a map of different actors coming from healthcare providers, the research and innovation community, citizen and patients. We have public bodies on one side, enablers that may help, and financial enablers as well. And then we have the industry that we want to present this unmet need for them to react and respond to it. So just to represent what the rather stakeholders look like and they come from, if you see the buyers, they come from different perspectives. They have different views, and this is interesting to realize that we can use this vehicle from all these different perspectives. Then we have the supporting entities that also, there are some different, from research innovation agencies or public bodies like ourselves, or other enablers, or even private enterprises or SMEs that can help the process. Then we have other other stakeholders like the Federico II Hospital, in which, in the case of UNINA, which is part of the university, the Federico II is when it's going to be applied, or as Sakidetza, it's going to be the buyer, but it's going to be on the Biodonostia Hospital and on the primary care from the Biodonostia region, where it's going to be applied, or VINCAT, which is the surveillance element in Catalonia, which is also inside ECO, but it's another actor that is taken into account. We also had interviews with experts from different perspectives to understand how our unmet need was validated, and how we can, introduce elements from researchers or healthcare providers or other public bodies or payers, for example. We had also debates with citizens and citizens organizations on AMR. We had conversations also with IMs in terms of how this initiative could, is aligning with what they're doing. Other agencies in the European Commission are also interested in what we're doing and how we're doing it to address the same AMR problem in a global perspective. And even we organized an event also with the World Health Organization. So this is just to say that this is the preparatory process. And at the end, there will be 4 contracts, which are those 4 triangles that will be awarded, right? And those contracts then define what will happen from here on. So what we use for the value evaluation framework is this value-based permeability methodology, in which what we do is we use the theory of change to understand where is it that we want to go in the future in terms of impact, and we go back to understanding what are the outcomes that will lead to that impact, the outputs that are more clearly defined, and then the activities in the short term that need to be addressed. And we also use this perspective of challenge agnostic results that was developed during PP, which is a community practice which we were participating on, that might have different levels in terms of the demand side. For example, starting from the patient side, the healthcare professionals, the health system, the healthcare provider, the health system, and socioeconomic elements. And all these are expected results that might be addressed on the procurement of innovation call for tender. So it defines where we want to go, and it also sends the message to the industry what we're looking for in terms of evaluating and measuring this impact. So when we had we did a market readiness assessment, which included a market sounding perspective. We had we had an international open market consultation event, and we had 4 on-site, each in Naples, in Paris, in Barcelona, and San Sebastian. And what we came out from these meetings is that the return and the interest from the industry is quite high. We had around 164 participants in the market consultation events. We informed more than 263, and what they were really interested in is that we are approaching this in a cross-border collaborative way, but also in long-term perspectives, so that we can address what could be for them interesting to invest in R&D, so that they can actually help us resolve our unmet need, but them position themselves in what would be those innovative solutions. So we come from this current, let's say, workflow. And first, we have sort of the suspicion of the infection. We have some test and extraction, the sample transfer. We normally go to the lab and wait for that, and then we do the test results, diagnosis, and the treatment decision control measures and treatment follow-up. And all of this has different challenges, like the lack of screening, difficulty for key data visualization, or complex sample extraction, all the elements that might be even, included in many of these phases, and then elements that might be addressed later on to take the decision on what is the right prescription that we need to do at the right time, right? So we used to define what is the object of the contract, what we expect to do, and using this theory of change, is what we expect to have an impact is a target medical prescription and treatment appropriateness, right? And we pretend to have this by defining outcomes that improve the integrated smart management in terms of patient management, pathogen management, sample management, and prescription management. And through this, we want to have a specific output, which is a healthcare professional data visualization, both for patient pathogen sample and prescription management, and a recommendation for pathogen and on-site management. And this will be also fed by patient rapid detection information system, an on-site and pathogen decision support system. This is going to be done by the short-term activities of MDRO detection, training and support, information access and visualization and data aggregation, and interoperability. So each of these elements describe also some specific activities that in the short term are going to be the requirements that we're going to ask the industry to develop a proposal for, and that we also have to integrate within our own institutions to provide this change management that needs to happen during the execution of the project. So basically, this will then endure into a new sort of workflow where all these elements, new elements like this radar rapid detector is going to help us have more accurate treatment and control measures through the patient rapid detection information system, the health professional communication system, the on-site pathogen infection control, and the rapid performance monitoring system as a global element for this shared need of common information that we're gathering here. So this value-based methodology helps us to define what the call for tender is going to be like, so in which we define what are the expected results, the object of the contract, the requirements, the awarding criteria, and also the monitoring and payment scheme. And this, why? So that the economic operators, the market, can propose and give those innovative proposals that respond to our unmet need, and not specifically to their, let's say, off-the-shelf products. And from here, we will award a contract that then will follow up a contract execution in which we will have a deployment and then an execution that we will contrast with the expected goals that we're trying to achieve, and that then will ensure, or that will help to generate new evidence on the scale-up market. So this call for tender has an impact on the future. And just to finish up, this value-based cross-border collaborative procurement had this different aspects of the common preparatory phase and the market readiness assessment, and we will then have 4 individual tender procedures at the end of this year, and then we expect to have the coordinated contract execution from the second semester of 2024 to 2025. So this is the rather project for you. Thank you for listening.
Well, thank you so much to all speakers for this 2 session. And now it's time for question. I know that the last time is not a problem for the Spanish people, but for the others. So please, if you have questions, I mean that we can take almost 2 questions, but please try to be short in order to allow to take almost 2 questions. So, yeah.
Yep. Just a question to Dominique Monet. I don't know, he's still online.
He's online. Is Dominique Monet connected?
I am.
Yes. Yes. Okay. Thank you.
Okay. Thank you. No, thank you very much for your presentation. I just wanted to, because it was very interesting to see the amount of conclusions that you were able to achieve with the GIACRA reports, crossing the figures and data that you have from vets and humans. And looking to the council recommendations, I was also thinking if for future reports, you were also considering to include the environment, or if it is something that at least has been discussed, or just that question from my side. Thank you.
Thank you. Environmental issues are under the responsibility of the European Environment Agency. And we have contacts together with EFSA and EMA with EEA, the European Environmental Agency. But the activities of surveillance are only starting there. So at one point, I'm sure there will be a way to cross all this, but not yet.
Okay, thank you.
Okay, thank you so much. Any other question or comment? No? In this case, back to you, the floor, Maria, for closing this morning session.
Thank you to all the speakers for your excellent presentations. We have seen during this morning how an overarching strategy allows to develop a lot of activities from different perspectives with different actors with the same objective to keep antibiotics, antimicrobials working. We have focused the tables on reporting and collecting data, how this must inform other policies and the prudent use of antibiotics, and how important it is to have diagnostic tools to achieve a prudent use of antibiotics. I have to confess that I am not making questions because it's too late, and I know this is too late for our European colleagues for lunch. But I would like to ask a lot of questions to Orman. I don't know in which part of the project you are currently, if you have achieved some products, because I guess that the market is developing these products to accomplish your demand and your needs.
Yes, and it's not actually like that. What we present is the, let's say, the public procurement of innovation of these 4 procedures. We are addressing our unmet needs collaboratively, but each one of the buyers is going to have an individual procedure because, as you know, AMR has also local elements to take into account. And what I presented as sort of that expected results from this process is sort of the global interpretation in which, at the end, each of the buyers is going to maybe handpick of the local activities that I pointed out, what they are addressing at the moment for their activity and the amount of procurement of each of the cases. So what we aim to have is then the publication of the call for tenders by the end of this quarter, and then the economic operators will have the information to develop their innovative proposals. So we're not asking for a specific technology, but rather to play with us so that they understand where we're trying to reach this transformational element of how we are approaching by defining this rapid detection, but also this smart management system as an integral solution that we will co-create with those awarded contracts. So it's on the contract part, which I guess responding to the first question and the first talk, that we will see then some results that have this economic interaction in terms of this innovative evidence that we will get from the 4 different procedures, and that will allow maybe for the scale-up of the solutions to be addressed with the evidence that we carried out during this execution phase, which is not enough time. This is by it's 2025, but it's some initial evidence. But we've already sort of foreseen the long-term impact of what we desire to do, and then from then on, it could be that this same buyers follow up on the continuation of this adoption of this innovative intervention, and also the possibility for the economic operators to reach a scale up within those same health systems, and to new health systems across Europe that might have a similar need, that might be closer to each one of the 4 evidence that we will generate with the project. But we don't. They're not yet generating anything because the call for tender has been not out. But they've approached this process with a lot of interest, since it has this systemic perspective on how we can tackle this in an outcome-based and result-based
perspective.
How interesting. We will follow your advances with interest because we are used to deal with many other issues which are clear market failures. And I think that this approach, PPI, could be helpful for some of our current concerns. And Dominique, tomorrow we will have the opportunity to count on you again during the table about integrated surveillance. And I think that many of the questions that we could have been discussing with you today, we will have the opportunity to discuss them tomorrow. I would like to remind of you that AMR is of priority health problem for most of European states. That's why you are here. That's why this is a high-level meeting. That's why tomorrow morning our Minister of Health will be introducing the meeting. And these kind of words will have a continuity during the next presidency with our Belgian colleagues. We took over the responsibility from our Swedish colleagues. Now we are in the middle of the meeting, trying to discuss, finding solutions, open our minds, addressing this problem. And May 2024 will be the next date during the Belgian presidency. And now time to have lunch. Thank you.
Hello, Bruno, hello. And welcome to this afternoon session. This session will be totally dedicated to the communication strategies. And probably all of you that agree with me that controlling antimicrobial resistance requires behavior change. There are many examples that all of us know about this behavior that drive antimicrobial resistance. For instance, antibiotic overprescribing or patients not using antimicrobial as prescribed. For this, we think that that is a very important topic, and in this sense, the following round table will be dedicated to these communication strategies, and we have here with us 5 very good experts to discuss on the different actions that are being carried out from the point of view of behavior change communication. And we are going to try to identify the main challenges and action to face this global health problem. So the moderator for this roundtable is Diego Pernas. Diego is head of the communication for the Spanish Agency of Medicines and Medical Devices. And he is also chair of the working group of communication professionals of HMA. And well, he are going to deal with this roundtable, and he present and introduce the different experts that join us this afternoon. So, Diego, the floor is yours. Thank you.
Thank you, Cristina. Yeah, as Cristina said, I think everybody is aware of the importance of communication and also dissemination to raise awareness and also behavioral changes. And this is something that we need to tackle with all actors involved. But in communication, we have like a slightly different situation. We are now living in the now with short-lived messages, with no context or little context, with fake news, a lot of information where it's difficult to find the regular one. And that's why we call AMR like the silent pandemic, because it's difficult to have the attention of the public. And we need to be perceived as useful, but also interesting, understandable, that's super important, and trustworthy. That is important for all of us. And on the other hand, communication knows no boundaries, so we need to integrate all communication. Every actor should have a coherent and coordinated communication, so we have both sides, and this is what basically are we talking today. So I'm going to present the different interventions. Danilo Lofo-Wong is the European Regional Advisor and Control of AMR from the WHO. He started working there in 2007, and since 2011, he is Program Manager on antimicrobial resistance with the responsibility to coordinate, this is something we already talked about, the work of Interdivisional AMR Working Group to ensure implementation of the European Strategy Action Plans on Antibiotic Resistance. So I'm going to start with you. How is your organization facing this silent pandemic from your communicational perspective?
Yeah, well, thank you very much for the question. And first of all, thank you very much for the invitation. It's a pleasure to be here. I think we were introduced as communication experts. I'm not an expert, but when I took the role as regional advisor, the first thing I noticed or realized is that communication is absolutely key when it comes to this. So when I started in the European region in 2011, the first thing I did was to reach out to other colleagues, especially also in the ECDC, that's been running the European Antibiotic Awareness Day since 2008. So this was something that I wanted to jump in and export it to the rest of the region. For most of you may be aware that the European region for WHO is maybe twice the size as the EU. They would go further to the east, to the Caucasus, to Central Asia, etc. And for in that part of the region, that kind of awareness raising was still quite new, so it's uncharted territory. So in 2012, or since 2012, we had these joint media packages with ECDC, which we then distributed throughout the region. In 2015, it was the first year we had the World Antimicrobial Awareness Week. Of course, so we started getting more materials and messages that we could distribute among the countries They're also being developed by colleagues in headquarters and ourselves. More increasingly, we were working with our colleagues in FAO and WOA at the time to start generating and these messages of more of a One Health approach or an intersectoral approach. Then as the years grew by, we also started realizing that awareness raising in itself is not enough, and it's also not enough to have 1 week per year where we have a lot of attention for antimicrobial resistance, and the rest of the year it's very quiet. So we started focusing a bit more on producing materials that could be shared throughout the year. And then taking the next step is to develop guidance on how to set up behavioral change projects and campaigns. And for that, of course, you need to be much more targeted. You cannot have, you cannot fly over the city and hand out pamphlets with the same message. It's not going to reach anybody. So we developed this guidance. We developed pilot projects on setting up behavior change campaigns, looking at different topics as to why are hospital personnel not adhering to IPC measures, or why are people still buying antibiotics over the counter when there's the possibility to do that, etc. The next thing that we also wanted to do is to help the dialogue between the doctor and the patient. So we developed this non-antibiotic prescription, where it's sort of guiding the discussion as to why you're not getting antibiotics this time, but you do get something that looks like a prescription, so you feel like you're listened to. You have advice as to what to look out for if certain symptoms do get worse, or you get a delayed prescription or something like that. And also posters for the waiting room, which you can have up all year, which could prepare the patient that they may not get antibiotics. They may not be necessary. And we have also these reminder posters for the GP to remind him or her that not everything needs an antibiotic and things like that. So I think finally, the most recent thing we've done is a survey, knowledge, attitudes, and behavior survey in 14 countries outside the EU, using the same survey as the Eurobarometer, just to create a bit of a baseline as to what do people know? How do they act on that knowledge or not, as a first step towards setting up behavioral insight campaigns afterwards.
Thank you.
Yeah, you're welcome.
Actually, I think you already talked about really interesting stuff, tailored message and One Health perspective. I think it's super nice. Thank you. The next one is Svenja Sander, the head of drug resistance in VVL. She is a DVM with a medical specialization in pharmacology and toxicology. It's difficult to even pronunciate. I cannot think of studying it. And she joined the Federal Office of Consumer Protection and Food Safety, the VVL, in 2017, and she worked with post-authorization surveillance and responsible for risk communication. And since February 22, Svenja has been head of drug resistance unit, which provides scientific and regulatory advice on the development and implementation of strategies to reduce AMR in veterinary medicine. So here, the One Health comes really handy. So we know it's crucial to have this perspective, but does this add complexity? There are options to join forces to address everybody else?
Yeah. First of all, thank you very much for the very kind introduction and for inviting me here, and to have the opportunity to stand here for the veterinary medicine side. So I think it's very crucial that we bundle our forces, and we should never forget that mostly we just don't address a patient or a veterinarian, because a veterinarian can be a patient and can be a pet owner. So we have all these different perspectives, and if whenever someone is addressing the issue, we help each other. So I think we could really profit from material, especially in my part in veterinary medicine, which we more could share, because, I know it's very specialized, so maybe it should be addressed to someone else, but just, I think it's I really appreciate the World Antibiotic Awareness Week, so Go Blue, was really great. We joined it last autumn. So that makes it very easy to communicate. So if you just have good guidelines, you get some good ideas to join, and which makes it easy. It's easier to spread and to communicate.
Thank you. Thank you. The next one is Camelia. I'm sorry, I'm super bad at surnames. Camelia Enakyu. Almost. She's communication officer and social media manager in the European Medicine Agency. Has 13 years of experience in this field, and also in public relations for key European Union institutions such European Medicine Agency, but also the Council of the EU and the European Commission. And at EMA, Camila has been overseeing the implementation of communication campaigns aimed at raising awareness on the threat of AMR. So EMA is the European authority, but shares responsibilities and competencies with national competent authorities. This is another example of need of coordination. What are the challenges and the successful examples you can share with us, please?
First of all, thank you very much for the invitation. I'm very happy to be here and share some of the experiences and challenges. First of all, I would like to mention that AMR is a key priority for EMA and also for national competent authorities. And it is a topic that affects every single one of us. That means that we need to have awareness campaigns that reach as many people as possible. And in the EU, this is the first challenge because we have 450 million citizens that speak 24 languages. They come from 27 countries with different values, attitudes, and this in itself adds quite a complexity for our work. We also need to consider that when it comes to how people use internet to get information on health-related topics, things are not so easy in the EU because there are even countries that have as little as 30% of their population that get their information online. That means that we always need to take into account other information channels like TV, radio, billboards. Diego mentioned the waiting room for doctor clinic with leaflets and other information materials. So we need to be creative and we need to embrace as many channels as possible. So, and that I get to the second challenge, and that's resources. And this is something for EMA, but also I'm aware for national competent authorities. This is why it's key to come together, to bring what we have, the expertise, the time we can allocate, to fill the gaps and to create synergies that can ensure some strong awareness campaigns. And maybe I can give a successful example in terms of EU collaboration that this year is the main topic for us during the European Antibiotic Awareness Day and World AMR Awareness Week. And this is the ESVAC project. I'm using acronym, although I don't like acronyms. I know that many of you know about this project. So it is a surveillance initiative through which EMA collected valuable data from European countries on the sales of veterinary antibiotics. And why is this data important? Because it can help us to identify risks of development and spread of AMR. And let's not forget, AMR spreads between people and animals and from animals to people. So that's why it's important to have this data. And what started as voluntary, this project started voluntary with 9 countries, and in 2022 there were 31 countries that were providing information and their data on use of antimicrobials in animals. This will inform policymakers and also empower the countries themselves to continue taking the necessary measures and improve where possible to manage to tackle AMR.
Thank you, Camila. So last but not least, we have Maria Santa Creu, that is the head of communication of the Spanish National Action Plan on AMR. Yeah, we will keep it local this time. Since all member states, no, sorry, I have to introduce you. Maria has a master's degree in communication and advertising management. She has more than 50 years experience in communication in companies, but also in the United Nations Food and Agriculture Organization. And now, actually, she is in this action plan. So since the member states were called to put these action plans in 2015, I already know that you have done a lot of different stuff. But can you mention some of that? Do you think that the member states have an important role, or how do they have to deal with this AMR?
Of course, Diego, thank you for your question. Yes, the National Action Plan have a crucial role. They are the means to implement the global actions at local level, at national level, and to adapt all the activities, the communication activities, to the needs of each country. Camelia gave a success story about a European activity, and I'm going to provide some examples of activities developed at national level. What do we do at national action plans? For example, here in Spain, we launch every year campaign, an announcement, and it's been done from the beginning of the National Action Plan. And the last 2 years, we had an announcement that raised the importance of using properly the antibiotic and not using them for a virus or a flu, and compare the situation with another absurd situation. So with a touch of humor, we catch the attention from the public. And to tell you some data, we launched the announcement on 2022 on television, and on 2023 in digital media and social media, and we reached like 13 million impressions on social media, and it was launched on the occasion of the European Antibiotic Awareness Month, because it's not only a week or a day, now it's a month, the month of November. And we've seen, after the evaluation of this announcement and this campaign, we have seen that little by little people is learning about the appropriate use of antibiotics. And we have detected also that the young generations, it's important to work on them. And next year we are planning to launch a special campaign together with DG Santé, with the Commission, especially focus on those generations, because it's important to change behavior from the beginning. And another successful activities, my colleagues mentioned the European Antibiotic Awareness Day and the Awareness Week. It's an important event, and we organize an event every year at the Ministry of Health. And last year, for example, we counted on with the presence of people affected by AMR. They came to tell to everybody about their stories. So this is, I think that when you put on other people's skin, you start to think about the importance of this theme. And they discuss and have a roundtable with technical people from the human health, the animal health, and the environment, because we, the National Action Plan, work on One Health. And it was a successful event. We had more than 2,000 people connected. And after the event, we disseminated on media, and our website received more than 20,000 visits. So it was a record. And last but not least, I would like to forget about our another target. Obviously, not only the general public is important, but also the professionals, the healthcare professionals. And we have a specific working group with universities, with biosanitary universities. And we develop a lot of activities with them. But we have also a popular race that we do every 2 years. And with these activities that we organize with the students, we also promote their behavior change and awareness on this theme from their careers. And also we have launched this year, the last year, 2 applications for human health and animal health for veterinaries and prescribers on veterinary and human health to support them and to standardize the prescription of antibiotics. These applications are updated every month with the last recommendations and critical use of antibiotics. And those are some success stories in our National Action Plan, and I'm very aware that a lot of countries are doing activities like this.
Thank you. Actually, the last thing you mentioned, and I think all of you mentioned it, was behavioral challenges of changing population. But what do we talk about when we talk about behavioral changes? And how do we measure something that is so abstract? How can we know if our campaigns or actions are actually working that way? The one you prefer?
We, for example, at the National Action Plan, we know that it is important to develop activities, but also to measure them and to know if they are working. So for us, evaluation is really important, not only at the end, when we finalize the activities, but in the process. Because if you do some little evaluations during the process, you can fix what you're doing wrong, or correct, or replace, or do something like this. And we use different tools, qualitative and quantitative. Quantitative tools like Google Analytics, statistics in social media, and qualitative tools like, for example, develop a survey before launching a special campaign, and after that to know, or before doing an event, to know if people have learned. Those are some examples.
Thank you. Anyone else?
No, and this is maybe where I can reveal that I'm not the expert.
Yeah.
But I think you're doing absolutely the right thing. When you mentioned some very impressive numbers as to impressions on social media, it's still very difficult to see what does that mean. Like, does it mean that people will remember, or they just seen it and they scroll through it? I think you cannot avoid talking to people or measuring with surveys before and after. So there's absolutely no shortcuts. We cannot guess what people think and what they do. And there are a number of tools for that. And I think one thing which also maybe makes it easier to evaluate afterwards is if you use the right channels. And I think this was mentioned before as well. We cannot use one message for all the populations or cultures, or even within countries, there's different cultures and different groups. And you need to find out, first we need to define who do you want to, which behavior do you want to change in which group, and then you have to target that. And then you have to find out, how do we target that? Who do this group listen to? They may not listen to WHO, they may not listen to a doctor in television, but they may listen to their school teacher, or to their to their minister. So there's
to an influencer.
To an influencer. So there's a lots of different channels, and I think in that sense there's no silver bullet when it comes to behavior change. And you really have to go target by target, group by group, and and this is also why it's important what you mentioned before with, taking hold of youth and making it second nature rather than trying to change behavior once it's already established and driving AMR.
Yeah, I would like just to amend that I think it's just like a puzzle, and we have different pieces, and at the end we are just looking on the consumption of antibiotics. So maybe we can see it years later when all fits together and everything helps a little bit. And in the field of veterinary medicine, well, we don't talk to the patient, but to the pet owners or to the animal owners and to the veterinarians. And they're really the crucial ones we have to reach, and they are the professionals. So I think in some points it differs a little bit from the target groups you have.
So I'm going to get a little bit wild and not ask her about this, but you were talking about it. So we are talking about general population now, how to reach, I don't know, older people or teenagers, but how to reach healthcare professionals, for instance, how to make them understand how important it is, because this is another target that it's essential for us.
I think actually...
No worries.
I think actually that might be one of the easier groups to reach, because you have them during their education, you have them as a captive audience, they have to be there to get their credits to finish their education. This is the moment where you start inserting the right knowledge, the right messages, and then also making sure that they can practice it. So one thing that we started to talk about is we stopped talking about behavior change, because not all behavior needs to change. We're talking about behavioral insight, because we can learn from people who are doing things right. Why are they doing things right as opposed to others? So there is something about enabling behaviors, and we've done this through focus groups as well, where some barriers are real and some barriers are perceived. If you do a training and you ask the people, so can you actually implement this? Say, I don't think so. I don't think my boss will think it's a good use of my time, or we have these timetables or these criteria to live up to. But then you have to tackle the problem and not necessarily the symptom, which could be the behavior. But healthcare workers, I think in many countries they have professional associations. They have meetings where they get together. These are really good opportunities to have a discussion, like here. We are like-minded people, so this is the right place to start that discussion, I think. Camille, I think you wanted.
If I may add here, I think doing a segmentation of our audiences is really important. For instance, to know exactly who the groups are that we want to reach. And gathering intelligence continuously is very important for us. For example, at TMA, we have regular meetings with patient organizations, healthcare professional organizations, different other stakeholder groups. We meet them in webinars, face-to-face events. We have public consultations. All these are ways of getting information from some people who represent a group, and we manage to understand better the bigger group. There are also digital tools that can help with this audience segmentation. For instance, we can understand better their interest, or what type of media are they consuming. And all this is important in order to know the people we are talking to and better tailor the messages.
You want to add something?
Yes, maybe I think the crucial moment is when the medicines are prescribed, the moment when the decision is made what to give and what not to give. So we need really easily accessible information at that time point, because when you're a practitioner, you're very busy and you haven't read the last paper about antimicrobials and what to use, what not. So at the moment when you're doing your decision or make your decision, you need this information. So I think we really should put our forces into that.
Actually,
I agree with what Svenja said before. Some professionals are easier to reach, and some others, like veterinarians, are more difficult to reach. And in this sense, I think, again, that the National Action Plan play a crucial role. For example, here in Spain, we have a working area on the veterinary side, and the National Action Plan here have working groups, and through the working groups and associations, they reach. For example, one successful example here in Spain was with the use of colistin. Through this working group in veterinary, through the associations here in Spain, and the work of my colleagues, we reached in less than 1 year and a half, I think, we reduced more than 92% the use of colistin here in Spain. So the way that, for example, nationally we work is with these kind of groups, and also in the human health, we have the technical scientific coordinator in every region of Spain, and they work together with the hospitals, and they implement the human guidelines in the hospitals. So we have a specific figure in human health to try to work more in depth in the hospitals. Those are some examples.
So actually, we're talking about the different audiences. Let's talk about ourselves. We I have you that are different organizations. How are you able to, or are we able to interact with each other? How can we, as you said, cooperate, exchange best practices, or even campaigns? How are we doing with that? What can we improve in this field? The first one.
It came to my mind, for example, the Technical Advisory Committee that the ACDC organizes every year. There, the communication teams of every national action plans, we have a meeting all together and we explain the activities we are developing, the campaigns that we are going to launch. And like this, you are aware of what other countries are doing. And also in this occasion of the Awareness Week and month, we always receive the package, the communication package from WHO, adapted to all the languages. So you receive a lot of materials already developed and adapted and translated into languages to raise awareness during November and during all the year. We use these materials during the whole year. Those are some initiatives where we can see what others are doing and successful stories and reproduce it locally.
Thank you.
Yeah, well, I think for the NCAs, the Working Group for Communication Professionals, as you know, can be a very powerful tool. So, well, it was maybe a little bit difficult the last years due to COVID, but I think just for the Med Safety Week, for example, there's very good coordination and spreading of information, and I really think that's a good way to spread information in between NCAs in Europe.
Yeah, actually, you were talking before, like crisis preparedness. Like after COVID, we as WGCP started working more formally, not only informally sharing best practices, but also asking what do you need and what can I give you. So I think that's much better. Okay. Also, we just to keep going through the different targets, we have talked about general public, but how do you work with academia to work in dissemination, in generate more knowledge about AMR? Do you have any actions in this field specifically?
Yeah.
Like interviews.
Go, Camille. Yeah. Sorry.
Oh yeah. I mentioned the campaign this year where we will focus on the surveillance initiative, and we will have messages targeting academia. And at EMA, we also have a formalized framework of working with organizations that represent academia, and we are in constant touch with them. And we also know that LinkedIn as a platform, in our case, is a very good channel to reach academics. And we see that when we want to have specific communication towards them, the engagement and reach among these groups are very good. So there are channels that can be successfully used.
Anyone else? Were you talking, Maria, already?
No, I think that by also promoting interviews with technical people, as you have said, here in Spain it's called the silent pandemic. So the media are starting to talk about this problem, this health problem, and they are looking for people to interview, and we are promoting to specific people that can explain it very clear. And also we have a special awards every 2 years, and one of the categories that we award is the scientific publications on AMR.
Thank you. Anyone else?
Well, we are involved in lectures at university, so we get in close contact with students and can promote this, and we are able to support some studies just for improving diagnostic. And,
a lot of activity, actually.
Yep.
Yeah. I think we're also doing the same, but it's a bit more sporadic. Of course, we get invited to do guest lectures in different universities, but I think in many countries, universities actually also have not a normative role, but a sort of an executive role in implementing things. So they're in some cases our natural counterpart. In other cases, they're a little bit further remote. But of course, they can also help with the development of materials or find the background data and evidence that goes into the awareness materials.
So you were talking about tailored message. Actually, Maria, you were saying that we're trying to use humor to make it more appealing. Let's say appealing is a little bit. But how do you find the messages that you, or the tone you want to use? How do you know what to say to the public you want to reach? That's the difficult question.
That's a difficult question. And actually, to be perfectly honest, I don't think we have it entirely right yet. I think there's an issue with the narrative around AMR. When we started more than 10 years ago on this sort of the momentum that we see right now, we use these doom and gloom messages like, now you're going to die from a simple scratch on your arm or your leg, and that doesn't really work. We've tried various different things, but I think what we continue to try to do is to have one message for the entire population, whether it's professional or political or the general public. And I think this is where we are going wrong. The other thing is also the complexity of AMR itself. It doesn't have a specific face or a voice. It doesn't have a very recognizable disease pattern. Like you see pictures of an HIV patient or a TB patient, and you sort of recognize that AMR is not a single disease. It's a complication of treatment of disease, and it goes across sectors. So just by default, we cannot treat it with one message, because there's different messages that resonate with different groups. I think this is what we need to work on. And also, I think you mentioned the personal stories. I think this is, again, to make it more relatable. There's some very powerful campaigns about everybody knows somebody with cancer. But 1/5 of cancer patients actually rely on efficient antibiotics. So there's more to these stories as well, and we need to explore that.
Well, I think what works best is just to go out and to see people face to face, and really the direct contact often really has the biggest impact. So if you go on congresses and have a big audience, but you have really the possibility to spread your message and to leave an impression.
Amelia? So agree with what has been said here, that we cannot have one message for everyone. So I think a very clear targeting of the audience groups is a good starting point. And what do we want to achieve? What is the objective of having a campaign for the respective audiences? I can give the example here of young people. Young people is one of our audiences that is being reached through Instagram. And I can give an example, a joint Instagram account that is a project with EFSA, ECDC, EA, the Agency for Environment, and ECHA. And together, we try to educate younger audiences, by younger I mean between, let's say, 18 and 35, about different topics on health, environment, and food, so under the One Health umbrella, including AMR. And we know that this channel is the right channel for younger audiences, but it also means that we are forced to simplify messages and to make them, to educate them in a fun way, because people are there, they are open to get educated, but while they are entertained. So for us, it's a very useful exercise because it forces us to be creative, and we work together as a team with the other agencies. And I would like to thank EFSA because it was their initiative to initiate this channel, and it's a great example for us of how we can work on some very clear targeting for an educational messages for a certain audience.
I agree that what Danilo said is a health problem that is difficult to explain. It's not as you smoke, you have cancer. It's very difficult to explain to the general public, and this is a challenge. It's our major challenge, but with the COVID, we have seen that we have a lot of scientific communicators, for example, on social media, that they translated all the COVID information into a common language for the general public. in a really good way. And people got used to get informed by them. So we detected this, and this year on the European Antibiotic Day, we are going to have some panels in the event, and we are inviting those scientific communicators that are going to tell us how they would explain the EMR to the general public, because they have a long way doing this during the past years for other health problems, and now they are going to support us and to help us to see the better way to communicate this.
Thank you. So I'm going to leave the floor, so if anybody has any question, or if no, I can continue, but please, if you can. It's coming. I think we're ready now.
It's on.
No?
Yeah, hello.
Speak, please.
Thank you. First to introduce myself. I'm Jean-Pierre Niemazi, and I'm coming from the WHO Geneva office. And I work as a... You hear me?
Yes.
Oh,
No.
Sorry.
Much better.
Sorry, in a session of communication, so things go this way. Jean-Pierre Niemazi, I work with the WHO as part of the Quadripartite Joint Secretariat. And I think Bijon gave you some idea of what the quadripartite is. I'm also not a communication expert. And I think the panel has done a good job by telling us the complexity and also showing us the strategies to move forward. I'll quickly speak about something probably you didn't touch. I think we need also to speak about who communicates. We most of the time focus on the who benefit from our messaging, but also if a scientific person goes to communicate with a community, farmers, and no, they will not get it really. So I think we need also to diversify of people about who are going out to communicate. And the first thing we need to understand is that if let's say a farmer speaks to the farmers, it better goes wrong, really. If a healthcare provider speaks to the healthcare providers, it goes well, scientist to scientist. So most of the time we mix, and then I go there as a medical doctor, and I go and I speak to farmers. No, it won't work. So I think we need to also focus on who communicates as we move forward. And we also need to learn on the other very complex issues. Let's pick climate change, which later on became climate crisis, which I also see AMR is going to be. I think there are a few things we can't copy from them, except maybe that it has taken a long time for the climate change to become really something that most people will grasp. But AMR is almost the same, really. When you speak about AMR, as you clearly said, not many people will grasp what you're meaning. And, unfortunately, communication has to touch the emotions. And we haven't been able to make AMR emotionally connected to what people really understand. So I like the idea of the stories, and I think we really need to enforce that. We need also to remember that, when you look at the climate activists, we really listen to them, especially politicians, we listen to them, rather than listening from the academia, right? So we need to be, I think, looking towards different ways of doing this, not continuing to air messages through the normal channels, through the communication experts, rather maybe look into how do we really sample the critical mass and critical people who can really air the message more than we can do. So I wanted just to convey that. Thanks.
Thank you. I think you were talking something like that, like using divulgators and influencers and be able to reach the people. I don't know if you want to add anything.
Yeah, we need ambassadors like the climate ones, I think. Let's look for them. I think we are walking this way, and let's see if we reach it soon.
No, just to say, I completely agree. We relate to different people, so we have to find out where the message is coming from. Do I trust this person? Do I think it makes sense? And the other thing I was also thinking, I agree with you, Sonja, that we need to get out and talk to people. The problem is we quite often talk to people who are already convinced. I mean, also here we're preaching to the converted, and it's actually frightening if you talk to people outside of this group, who is quite diverse. They know nothing about AMR, and we think it's the most important thing in the world. And we see this image like, okay, we need to act now, but other people are blissfully unaware of the dangers, and they continue to do what they're doing because they can, or nobody tells them to do otherwise. A few years ago, just a quick anecdote, sorry. One of my most interesting meetings was when I was invited by the European Bank of Reconstruction and Development, like the European World Bank. And I was telling them all about AMR, and they were thinking about how that threatens their investments. And I found it very frustrating, but also very invigorating. Like, yes, here's an audience that doesn't get it, or that has different motives, different way of engaging with this. And it's like, okay, this is interesting, this is important. And they were talking about, even sum game, or making sure that that your gain is more than your investment. And I was like, but what if health costs anything? I mean, health is the foundation for. Health population is a foundation for economic growth and all these things. But there's still a way to go to reach the other audiences that are not used to thinking and talking about AMR. And I think that's where the challenge is. And it's a very big group.
So how do you identify them? That's the difficult part,
I think we
guess.
need to get out of our bubble, in a way. Sorry.
That's where the collaboration comes in, because we can't do it on our own. It's not just EMA doing it on its own, or the Spanish National Competent Authority doing it on its own. So we have to come together, and maybe it's also the right time to start having innovative, creative approaches to communication as well, because sometimes some advertising campaigns with low budgets that are creative can have a huge reach and a major impact, but we need to get to that point, to get that spark. And this can come actually from coming together and sharing and brainstorming and trying to be creative. And I will come back also to the idea of influencers. I think influencer marketing is something that can help a lot with reaching those people that otherwise we can't talk to. Maybe influencers are for different target audiences as well, for academics, for healthcare professionals, for patient groups, and so on. So we need to put maybe some efforts in identifying those.
Okay, thank you. Any other question? Oh.
Thank you. Saija Kalenius from Finnish Food Agency, so from the veterinary sector side of things. But I was wondering about the concept of behavior change. We tend to talk about communication when we talk about behavior change, and of course this is just one part of it, because awareness is not action. And oftentimes, because I don't really have a behavior change background, but I do understand incentives. So what I'm left wondering is when we put resources in communication campaigns and trying to educate the grand public and veterinarians and farmers and whoever, is that do we know what we are doing? If we are asking them to do something, have we made sure that they are actually able to do this enabling that behavior part of things, and how to get there? To if we tell them that we would want you to do that, what would have to happen? What would they need to be able to make that move for us? And I have a question for everybody on and off stage. Do you have communication campaigns that are based on a thorough analysis of people's behavior, even if it's just one small part of AMR communication? Anything would help. that sort of looked at these incentives and looked at, for example, what would the doctor need to have the courage to not prescribe antibiotics on this case? What it is that they need to make this change? Is it just social pressure, or is it something in the diagnostics, or are they able to do this thing that we are asking them to do in this information campaign? So if anybody has papers like that, or even better strategies like that have really looked at this side of things and based the communication campaigns on that knowledge, I think I would find that immensely helpful. Thank you.
Thank you. We have a lot in our plate now, so which one want to start?
For example, regarding the second question, the incentives, I have an example for on the veterinary side. The National Action Plan in the veterinary area worked with the farmers to implement biosanitary measures, and we provided data to convince them that if they implement this, at the beginning you have to do some investment, but in the end you will see the benefit. In the end, you will have less animals with infections, you will spend less money in antibiotics, and we show the benefits, the incentives you mentioned on this side. And I think the first thing you said is important, not to work the communication area on a silo, but to work together with the technical area to know. Oh, sorry, I don't know, it's me. No? To work together with the technical areas to see how to communicate and to prepare and to do to develop tools, for example, for those professionals, for the prescribers. We have to convince them to prescribe properly, but when they have like 5 minutes for each patient, we have to provide them something to help them to do this prescription correctly and quickly. So we developed this application. Once they have used it several times, this is very quick to see the correct antibiotics. So you need to communicate to try to change behavior, but providing tools and, as you said, something to support them.
To build on that, because I think it's of course really important to know what to prescribe, when you need to prescribe, but it's probably more important when not to prescribe. And this is a little bit what I mentioned before, and I thank you very much for your question. It's extremely useful with this non-antibiotic prescription, which has a list of symptoms, and based on these symptoms, I'm not going to prescribe you antibiotics today for this and this reasons, but look at these and these symptoms. If they get worse, you don't get better within 3 days, call this number or do this or this. So it helps the practitioner not to prescribe. And then there's actually, and I'll like to put our colleagues from ICARS on the spot. There's a very interesting project going on in Kyrgyzstan right now, where with a very simple additional diagnostic test, you strengthen the argument of the doctor not to prescribe, because it'll tell you whether it's a virus or a bacterial infection. But before we go there, just quickly on the animal side again, I think a lot of evidence went into the growth promoter ban, because I think farmers were worried about, well, if I take growth promoters out, will I lose part of my profit? And I think that took, of course, a lot of work. But now that there's a big part of the world where they ban growth promoters, that part of the world can also start demanding for, if we want to import from you, we don't want you to use growth promoters. So it is like a circle in the water. But maybe if, with your permission, if ICARS could say a little bit more about the project, because I think it's very promising.
Thank you very much for the opportunity. My name is Sujit Chandy. I'm the Executive Director at ICARS, which, for those of you who don't know it, it's the International Center for Antimicrobial Resistance Solutions. and this is my colleague, Director of Operations, Hele. So we at ICAS, started by the Danish Health Ministry, with a view to actually engage with low and middle income country governments, but also researchers, institutes, and at the community level, to look at exactly what you're saying in one sense. We do have these policies, we know a lot of the evidence, but how does it relate to on-the-ground acceptability, adoption, and sustainability? So one of the, which Danilo was alluding to, one of the projects that we did in Kyrgyzstan actually, was that there was a lot of antibiotic use, especially in children with upper respiratory infections, and that's well known. And one of the things that people really requested for, and the government also, was having a point of care diagnostic which is cost effective and acceptable. So we tested this out with the CRP, and we found that initially that, of course, what is this is the question in everybody's mind, that extra blood sample or whatever it is. But then we found that parents were coming back to the doctor and saying, can we have this? Because we also want to know whether it's bacterial or viral. So this buy-in, understanding, and let me put it this way, belief in the system is important. And now we showed around, I think, 45% reduction in antibiotic use, and now they're scaling it up to adults as well as trying to put it into the guidelines of the country. So this is the example that I want to narrate, but I also want to say from a communications point of view, for a long time I was working in India, and there are three things which drive people. So if you look at farmers, and we're not talking about large-scale farming here, people's livelihoods depend on it. We're talking about people whose children or themselves, if they don't work one day, they don't have the money to pay food. So in that kind of a situation, whatever we do in communication or in policy, there are three things which drive humans, and you can narrate it from your own experiences probably. One is fear. Second is emotions. And I'm sure a movie that interested you when you were a child, you still remember it because it's there right inside. And the third is, unfortunately, whether we like it or not, economics, livelihoods. So whatever we do needs to touch into at least one of these three, and there might be more, but I'm just saying it now because of lack of time. The communication angle has to get into one of these three also, right? Besides doing the normal thing that we are taught to do in communications. So tomorrow, actually, there's the global launch of the WHO person-centered approach. I'm speaking on that. This is soon after the 3 o'clock to 4:30 tomorrow, where we're trying to move it from bugs and drugs to what I say as hugs and jugs, okay? Because that feeling, the emotional connect has to be there. And secondly, the jug part, you might be wondering what that is, okay? People need to survive, water, livelihood, okay? So if we can incorporate those things into our communication with the right tone, with the right texture, I think we'll go a long way into getting people to buy in. If we're not touching any of these three areas, then of course it becomes much more difficult. We're currently working in around 30 projects in around 16 countries, and every year we increase by 6, but it's been a learning experience. People on the ground have their own systems. They have their own ways of doing things. We, on the other hand, may have our evidence and policies and science. The question is how to bridge that, and that is through communication. Thank you very much.
Thank you.
Question.
Please. Please, if you can bring the mic to the front line.
Yeah, thank you so much, and thank you so much for this contribution. I think it's very important. And when I'm just thinking about communication, it comes into my mind, especially when we are thinking on communication globally. First of all, I'm very thankful that you have this session. I think it's key. We can do whatever we want on the regulatory side. If we have no good communication, we will probably not succeed at all. And my question is, first of all, I would be thankful if we're going to exchange even more. I got the impression that we can do more on this and probably reuse some materials that are used in different member states of the European Union or even globally. On the other hand, it just came into my mind when you were just reporting it was excellent, is that probably we need different communication in different areas of the world. So probably what scares people in Asia may not scare people in Europe and the other way around. So we need probably different communications which are adjusted to this different, to the different public in the different member states. So is there, what's going on in this direction? Do you have any ideas how to probably address this differently? And second question is, well, finally, it's some kind of competition of attention with other issues. And sometimes what I'm doing with my students at university, we have some kind of ranking of risks, felt risks and real risks, acute risks and chronic risks. And you could imagine that those felt risks, the emotional risks, are deviating substantially from real risks. So if I'm just thinking in Europe, we have this discussion right now on glyphosate. 70% of all people in Germany are scared of glyphosate use because they think it's really dangerous. So if you just break it down around toxicologically, it's way apart from antibiotic resistance. So it's from myself, antibiotic resistance scares me way more than glyphosate. Nevertheless, if you just have it on a list, and if something else coming up, for instance, if we have the Antibiotic Awareness Week this year again, and something happening anywhere globally, unfortunately we have many things happening right now, these things scare people much more. And as you said, financially, finally it breaks down to financial issues. So if people are unsecure how it's going to be in the future, maybe on different levels in developed or less developed countries. Even in highly developed countries, people are scared for financial reasons, and this overlays all the other scares. So how can we probably achieve something to put it in order and tell those guys outside that antibiotic resistance is something they should really be worried about, and probably not be worried about other things like glyphosate is of course very difficult, but anyways, we have some other things going on. So this would be my two questions: different communication, and second, how to rank risks and how to make clear, also from the WHO side, what are the real risks that we should be worried about?
So I think two excellent questions. No, about diversifying, absolutely. It sort of dribbles down in a way. We have very close communication and collaboration between the different regions and with headquarters. There's some global messages that then get regionally adapted, that then get offered to member states, that then can adapt it even further, which is one way of diversifying. And we do realize that there's very big cultural differences between regions and even within regions, because regions are very diverse. So I guess also there's no shortcut along that. We have to identify, adapt different materials, but there is a lot out there. There's a lot already out there that can be reused, and it's still timeless. I mean, the same messages as for 10 years ago, 15 years ago, they're still very valid. They're just not necessarily reaching the right people. So this is, I think, the real challenge is the channels that we've been talking about. How do we get these messages across, and how do we get this to actually lead to behaviors that are not driving antimicrobial resistance? And the second part of your question was about the ranking of risk. Yes, I think WHO historically has been trying to do that through this global health report, where everything is expressed in dollars, which is then the health currency, where you can start comparing different diseases or threats. And I think it's still very challenging because this is also our own fault. We're all trying to claim as big a part of the pie as possible because we all believe in what we're doing is more important than what the others are doing. And then again, as I mentioned before, AMR is an additional complication. There's, a person can die or be handicapped for different reasons, and AMR can be a part of that, but how do you account for that? It's a tricky question, but of course, ultimately, also what I've started when I started to preach AMR 15 years ago, I started saying, well, it may not be the most important thing, but it should be up there in your top 3. That would be my best guess. And a lot of things that you are doing to address AMR also benefits other areas like the health system strengthening, primary healthcare, emergency preparedness. So it'd be very difficult to have a very strong ranking that everybody believes in and would buy into. But I think if you can tell the story as to this is also helping other health threats, then it's really important. And then one last thing, I think another thing that we could be using more is our COVID experience. I think for a short while we were all scared to death. There's your fear of a disease. I hope that was not me. Of a disease that rages through the population for which there's no cure. There's a little sneak peek of what it would look like if we run out of effective antibiotics. I think we should not let people forget that.
Anyone else wants to share anything?
I'm off, no. The last thing you said, now it's more common to see on the media that somebody died for an infection, a complication with a specific infection. In the past, it didn't happen. Sometimes people is affected for something, but they didn't usually said that in the end, this person died for an infection. Probably you go to the hospital for a specific thing, and in the end, this person died for another thing. And now I think that not only in the hospitals, but in the media, it's more common to see those information.
Okay, so we are running out of time, so we have time for one last question. I don't know which one. Do you prefer?
Prioritizing.
Okay, so okay. Sorry, it was the long journey.
My name is Javier, and I work for the World Organization for Animal Health. I'm also a part of the Quadripartite Joint Secretariat, as my colleague from WHO. Thank you for this excellent discussion. And I want to bounce on something that he mentioned. Well, first of all, congratulations for bringing back again to life CRP, probably one of the most oldest biomarkers in terms of making the difference between viral and bacterial, and it's very useful still nowadays. So, fear. Where does the panel think that the threshold has to be put between mobilizing people and panicking people?
Yeah, good point.
That's a difficult one. I prefer yours, please.
Well, I have some information of a recent study of the organization Wellcome Trust. I think the study was conducted on 2020 or 2019, and this was focused mainly on behavior change, on AMR, and they concluded one of the main conclusions was that now, regarding AMR, people do not get mobilized by fear, but those data that in 15 years, I don't know how many millions of people will die, it doesn't work anymore. Their conclusion was that. So I agree with you that depending on the country and where are we working, that's the reason why the national action plans and the offices of WHO and United Nations organizations are important, because they work locally and they adapt the communication tools locally and the messages and so on. But I agree with you that emotions are mobilizing people in a lot of senses, and emotions with a little bit of fear, but more emotionally. I don't know if I'm explaining it properly, but this study concluded that, and it was done in Europe, in all the countries, and we are basing our communication on that. And also after COVID, people see catastrophic data and they switch off. So we are now doing more a call to appealing the emotions, like humor or like the personal. What I told before, the last year on the antibiotic day, we have people talking about their experience with our resistant bacteria, and I think that this will work. It's working for us.
Just to say that hope is also an emotion, and so is a sense of urgency. So I think you're absolutely right. It has to be a cocktail of things. If you really feel like, okay, there's nothing we can do, then we're going to party like it's 1999, right? So yeah, it's a balance. But I completely agree that these doomsday scenarios, unfortunately, they don't work.
I also think that the data is there. We have numbers that show indeed this is a big threat, number 3 among the EU threats. But at the same time, these are numbers only. So if they are being read on a screen, a number is a number. We need to put it in a perspective. Probably we need to have a more human-centric approach to put the human face on these messages more, to find those people that are relevant for our audiences. We mentioned the influencers, we mentioned those actors that are being trusted by those who we want to talk to or who we want to listen. So more human approach would also be important. And you mentioned very well, Maria, the storytelling. That's something that I recognize at TMA we can do more, and hopefully we will be able to, together with the MCAs, to do more together.
Thank you. Do you want to add anything?
Well, I think it's a little bit different in the veterinary sector because the use of antibiotics is highly restricted. They are unregulated, so we often have to sell the regulatory framework and to explain why it is really necessary to follow the regulations, and that's a quite big incentive.
Okay, so we just ran out of time. Just so you know, you will have an email, and it's also on the website. Please, if I say it wrong, correct me. You have all the information for the transfers, for the social visit. It's going to be a visit around Pamplona that I think it's quite interesting. You have it on the website. You can ask outside, and you have it in your email, so I don't think it's very difficult. Thank you for asking and for joining us.
See here on the QR, you go directly to the website, and there in the more information section, you can see the meeting point for this afternoon event and the dinner.
Okay, thank you very much. Yeah, thanks to you, you make it super easy actually. You talk a lot, and that is super. I did it wrong. Sí, porfa. Ahí ya está, ¿no? Please don't leave. Don't leave. Sorry. please, before leaving, we were trying to make a group photo. So I don't know where do you have to go, but just don't leave. And that way? Okay, just please go to the entrance and we will meet there, I guess.